part of this International Cardio-Symposium of Exercise, Sports, and Rehabilitation. Ricardo Stein and I came up with this idea to offer our students, PhD, master degree, MD students, your fantastic knowledge in the subjects that we are going to present to cover during these 3 days of symposium. As we went on with the idea, we expanded it, and now we are offering to a very large audience around the world, and I hope they take advantage of the opportunity to learn with you. Thank you again for sharing these moments with us. Please, Ricardo Stein, Professor Ricardo Stein, go on with the symposium.
Okay, Professor Sandra, thank you very much, not only for the words, but for your support to make this happen. Good morning, ladies and gentlemen around the world. Good morning, good afternoon, good evening, and good night as well. It's a big pleasure to be here this morning in Brazil, in Porto Alegre. And this discipline, actually this symposium, in the beginning was only a discipline from our post-graduation course in cardiology and cardiovascular science. Sandra and I, we have the idea to make the symposium, and right now is something beautiful that we are starting. We have more than 65 registration from all over Brazil and Latin America in the discipline, and I don't know exactly how many people are watching us right now, but as Sandra mentioned, this is something very special because a real dream team from different continents accepted the invitation, and they will give us an incredible symposium. We will start with a friend from actually he's from UK, but he's living many years in Doha, Qatar. Dr. Nathan Reading, after obtaining his PhD at Liverpool John Moores University in UK, in conjunction with Aspetar, a hospital in Qatar, he is currently a scientific researcher at Aspetar. Aspetar is a big sports medicine hospital in Middle East, and he's conducting research in athlete's heart and cardiac screening. Dr. Nathan will give us the first lecture of this symposium, and he will talk about the athlete's heart and its influencing factors. It's a big honor to have you here with us, Nathan, opening the symposium. And right now, I will give you this 35 minutes to give us a lecture. Please, Nathan, be with us.
Thank you very much. Thank you. If I do this, I hope everybody can see my screen. Can you see my screen okay? I would take that as a yes. Yeah.
Okay. I can't see your slides.
Oh, that is a problem.
There is no hurry at all. There are people just waking up, and there are okay. People just going to bed, so no problem.
Okay, we will get onto it. There we go. So.
Oh, okay.
All it needed was for me to press share my screen. It's 3 o'clock in the afternoon. I should be alert right now, but
No problem.
Hopefully that's okay. You can see my screen okay now, I hope.
The screen was visible, but right now
Right now it's not.
it's not.
Okay. How about now?
No.
No.
Share screen.
Yeah.
Below.
There we go.
Fantastic.
Wonderful.
Go ahead, my friend.
Okay. Thank you very much. Okay. So ultimately today I am, well, first of all, Ricardo, thank you very much for giving me the opportunity to present. In really, like, I am so honored to be in the same breath as some of the presenters on display here today, and yourself, of course. I've probably got the unenviable task of going through the athlete's heart and its influencing factors. I say that because there are quite a few. I'm going to be going through age, sex, body size, ethnicity, and type of sport and training intensity. Now, it's important to note that we can't really take all of these factors in isolation. They overlap significantly, all between each other in various ways. And so throughout the lecture, I'm going to be talking about each of the components, but we have to bear in mind there is this overlap. I'm going to be starting really at the very start. Most athletes' heart research presentations start in ancient Greece, talking about Philippides and his race to marathon. But this time, I'm going to be talking about etymology and the definition of what an athlete is. The word comes from athlin, meaning to compete for a prize. If only it was this simple to define the name of an athlete. It's not. Within the previous 11 iterations of guidelines and eligibility recommendations, I noted that only 4 have the same definition of what an athlete actually is. And it makes it difficult when we are trying to compare athletes' heart research if we do not have a defined definition. It's shown, for example, in the International ECG guidelines, where an athlete is defined as somebody who engages in regular exercise or training for sport or general fitness, and typically with a premium on performance, and often engaged in individual or team competition. Now, these vague terms do make it difficult for us to compare athletes' heart research. Particularly, I know that these guidelines are not necessarily created to be the gold standard definition of an athlete, but a lot of studies use them to try and justify the use of athletes in their research. We can't simply do it based on performance or a will to win. Training volume is incredibly important as well. And the latest guidelines, this time for those with cardiovascular disease, have suggested that an elite athlete is somebody exercising training over 10 hours per week. It's important to note, for example, in our institution, our football players may be training 6 or 7 times a week and for 2 hours. But is 2 hours of stimulus, or is it actually that they are maybe practicing football for an hour and there's a lot of downtime in between? I say this because you can see myself there, shamelessly put myself in the presentation, but I was a national level middle distance runner. And there was no way I was training 2 hours per day, except my training intensity was probably significantly higher. And so we have to account for training intensity as well. At the bottom, you see the definition of a recreational athlete. Are these athletes? And indeed, is 4 hours of exercise a week enough for cardiac remodeling? The study by Dawes has suggested that anything between 3 and 5 hours of training per week, or in fact anything over than the physical activity recommendations, is enough to elicit cardiac adaptation. We have to bear in mind that this study used athlete recall. So at the end of a year, they get asked, how often do you train? And we know the problems with this because a lot of people would simply overestimate their training volume and intensity. We know, however, using training studies, that training adaptation is elicited even from 3 months. And this has been shown not only in this really nice study from Ben Levine, but also 2 other longitudinal studies from Sanjay Sharma's group and also Aaron Bagash's group as well, who tracked non-competitive individuals and tracked them over 17 and 18-week training period, and determined using either a training supervised or training unsupervised whether they showed cardiac remodeling. It was interesting to see once again that training volume was a factor here. We see this in Ben Levine's study where, like I said, adaptation is found within 3 months. Interestingly, left ventricular mass increased significantly from baseline through 3 months to 6 months, but this was not followed by end-diastolic volume. It was in fact wall thickness that increased significantly from baseline to 3 months, suggesting that there may be a concentric form of remodeling at the start, followed by eccentric remodeling further on. And you see below in the background there, that is a training load that they undertook. And so it started out quite low. And this is kind of suggested that this form of cardiac remodeling is found within pre-adolescent to adolescent athletes as well, where those at the start of their adolescent sporting career showed more concentric remodeling than those at adolescent age who, following the continuation of their training, showed a more eccentric response. It goes against another, I think, Aaron Bagash study, which showed that ultimately the inverse was found, where in already trained athletes, eccentric hypertrophy was shown at the initiation of training, followed by a more concentric response further down the line. They suggested that this may have some role to play with plasma volume expansion, and then a further kind of like equalizing of the cardiac geometry as training progressed. It links into this Morgan-Ross hypothesis, which you've probably all seen. It was just based on one study many years ago now, which suggested due to the preload or volume kind of increase that we see repetitively in endurance sports, that this may elicit eccentric hypertrophy. On the contrary, resistance-trained athletes would show a more concentric level of remodeling owed to an increased afterload stimulus. There's been a couple of systematic reviews and meta-analysis that have supported this finding within endurance athletes. We have to acknowledge the fact that when we are comparing studies once again, we have to note that training volume and intensity is not always reported the same. And so we have to account for that, but also the fact that within echocardiography, the echocardiography inter and intra-observer reliability can vary quite significantly as well. And so we have to acknowledge that when comparing studies again. Ultimately, the study by Utomi showed that endurance athletes do indeed show more eccentric, more cavity dilatation. But this was also similar for increased wall thickness, where endurance athletes showed wall thickening similar to that of resistance-trained athletes. The reason for this may be that endurance athletes such as cyclists undergo isometric strain, which may increase afterload. And similarly with rowing, another previously endurance sport, that in the catch phase of their rowing stroke, they are pressing against water resistance, potentially again incurring a more afterload stimulus. It's important to note that when we think about cardiac remodeling in a pathological sense, such as aortic stenosis or hypertension, that hemodynamic burden is there the whole day. And so it's not really surprising that in endurance athletes, which are exercising for longer, indeed the elite may be exercising for up to 4 hours per day, but cardiac remodeling is more. Similarly, training intensity and level of the athlete has been shown to be important, here from Liverpool John Moore's group, which showed that the difference between elite cyclists and sub-elite, which were already at national level, showed significant differences in terms of their eccentric and concentric hypertrophy remodeling. This was also supported by findings from André Lagerche in 2012, which showed paralleled increases from left ventricular and right ventricular adaptation to VO2 max, again highlighting the importance of fitness and training intensity. Training intensity has been suggested to be included in the definition of an athlete, but that was done using metabolic equivalents in the algorithm. We have to be careful when using such parameters because we know that using a metabolic equivalent overestimates VO2 max by 35% and the underlying basal metabolic rate by 20%. So it may not always give us reliable results here. As we see, the endurance athlete, again in this study from another study from UTOMI, from Liverpool John Moore's, showing endurance athletes showing more non-normal remodeling. Interestingly, you see no resistance trained athlete showed concentric remodeling or hypertrophy. And this ultimately contradicts findings from a 2000 meta-analysis from Babette Plume, but also a longitudinal study from Aaron Bagish. Interestingly, they used American footballers as their resistance-trained athlete. And we know future research has suggested that these American footballers may undergo increased blood pressure, and also with weight gain, it also may lead to a more concentric form of remodeling, potentially suggesting that it's more than just resistance-trained athletes as the stimulus there. The other studies have shown that this Morgan-Ross hypothesis also fails with the concentric notion of remodeling among resistance-trained athletes. And again, in particular, when we think about what a resistance-trained athlete is, it's very different, a weightlifter versus a powerlifter, and it's shown in their remodeling form as well. Importantly, no athlete showed concentric remodeling in this study. And it's important because when we think about what happens in resistance training, systolic blood pressure, of course, increases, but the actual load of that increased systolic blood pressure may actually be for only 7 minutes per session. And is that really enough stimulus? Furthermore, with the Valsalva maneuver that often occurs when weightlifting, this increases intrathoracic pressure, which may ultimately go to normalize transmural pressure as well, and therefore, not showing a significant increase in the wall stress or indeed afterload, suggesting that an increase in afterload may not actually occur in such resistance-trained resistance training. Important to note that previous studies which have shown exaggerated concentric remodeling among resistance-trained athletes may be due to the use of anabolic steroids, particularly in the old research. Ultimately, however, we see both along the Y and X axis of wall thickness and cavity dimension that cycling, rowing, and canoeing are still there as the top-ranking sports. This ultimately leads into the upper limits of physiological normality, where both Antonio Palicha and Greg White have suggested, that wall thickness upper limit should lie between 13 and 16 millimeters. In the Palicha study, out of 1,000 athletes, only 16 had a wall thickness of over 13 millimeters. They were all elite endurance sports, such as rowing and cycling. This also kind of endurance adaptation and relation between intensity of sport and level also goes along with the ECG. This nice study from Sanjay Sharma's group showed this, where using both the Seattle criteria and the refined criteria of the ECG interpretation, shown that there were significant differences in the prevalence of an abnormal ECG, depending on this type of sport and the level that they were at. Indeed, two studies in endurance athletes showed that, of course, most athletes show training normal findings, such as bradycardia or Sokolov criteria for LVH. But ultimately, in the bottom study there, you see that up to 30% of elite endurance athletes showed a training unrelated finding. This was using the old 2010 guidelines. Using the 2012 Seattle guidelines, this prevalence of a training unrelated finding decreased to 4% in that top study there. This is ultimately related to increases in right ventricular hypertrophy, but also the presence of T-wave inversions in endurance athletes. So ultimately, going back to that, I guess, ultimately, we do need to be considering training intensity and volume when looking at not only the athlete's heart from a structural point of view, but also the ECG. As I move on to ethnicity, this is particularly important with regards to the physiological pathological crossover. And it's not only important because the incidence of sudden cardiac death from this study using NCAA or collegiate athletes in the USA showed an increased prevalence or increased incidence of sudden cardiac death among Black male collegiate basketball players. But also this ties into the increased wall thickening that is also seen among African and Afro-Caribbean athletes as well. And so this kind of lies in the gray zone of physiology and pathology that we need to try and elucidate. Ultimately, when I look at a study, I look immediately at the age and body surface area. And so I think, is the difference here simply due to the fact that the white athletes there had an average age of 17, suggesting that they were predominantly adolescents? And the decrease in body size could be another factor as to why there's differences here. They showed, however, the same group from Sanjay Sharma showed that even using athletes with similar ages and body sizes, the wall thickness was similarly high among Black athletes when compared to white athletes. Importantly, 3% had a wall thickness of over 15 millimeters, which goes into the territory of potential hypertrophic cardiomyopathy. So it's important to try and really identify, like I said before, whether this is physiological or pathological. It led to them suggesting that the upper limits of physiological normality move from 14 to 15 millimeters. Similar findings have been shown in the ECG, where T-wave inversions have been significantly more common among black athletes when compared to white. And again, another study from Sanjay Sharma. Compared to Black controls, however, who also showed a more increased prevalence of T-wave inversion than compared to white athletes. You see here in the anterior T-wave inversion that the prevalence of them is significantly greater than that of the controls. When we move over and look at Black individuals with hypertrophic cardiomyopathy, however, you see lateral T-wave inversions predominate here. And particularly when looking back at anterior T-wave inversions, and also to some degree inferior, let's focus on anterior here, however, that the prevalence is constant between the hypertrophic cardiomyopathy patients and controls, significantly higher among the athletes, suggesting that there may be a potential response due to exercise and training. It's supported, I guess, by the fact that in the athletes, the presence of features associated with hypertrophic cardiomyopathy, again, such as Q waves or ST depression, are really quite rare. It ultimately led to, in both the Seattle criteria and the international guidelines following up, that should a T-wave inversion be found in these athletes, in the anterior T-wave inversions with ST segment elevation, it was to be considered normal. Importantly, however, the terminology is Black athlete or African athlete, Black African athlete. But can we really use such terminology? especially when we consider the fact that within Africa alone, you see the difference in geography from the Saharan desert plains compared to the East African Rift Valley. Ultimately, important to note that there are over 2,000 different ethno-linguistic groups within Africa alone. And the genetic differences in Africa are more pronounced within Africa than between the other continents. It's important because we found that East African athletes showed a significantly lower prevalence of T-wave inversions than what we showed before. And it's not that much higher than when we compare them to North African athletes. However, compared to West African and Middle African athletes, you see this difference is very significant. It relates to the normal finding of an anterior T-wave inversion with ST depression, because it was only found in 1.5% of East African athletes. And it makes us think, is this really a normal finding, given the fact that it occurs so infrequently? More research needs to be done, really, to try and elucidate the differences here. When referring to abnormal ECGs, again, another thing is the fact that is it likely that between 6.4 and 8.5% of these athletes from West and Middle Africa harbour the potential for pathology? It's unlikely. So again, more work needs to be done to try and get a better understanding about this. When we look at the echocardiogram, we see those with left ventricular hypertrophy 0% among North African and East African athletes, compared significantly to the 5 and 5.5% in the other regions. This may go some way to explaining our previous findings in 2012 or 13, which showed that the prevalence of a left ventricular wall thickness of over 12 millimeters was similar between all ethnicities, and indeed only 0.5%. This may have been explained by the fact that we may have just had more East African athletes. When looking at geometry, Middle African and West African athletes had more concentric remodeling and hypertrophy. Importantly, when looking at the wall thicknesses themselves, even after accounting for body size by scaling allometrically, Middle African and West African athletes still had higher higher wall thicknesses. Importantly, however, most of the research so far has just come from North America, Europe, and Australasia. And we know the world is not this small. And when we look at research from other areas, we see that in West Asia, the number of studies is quite low. 4 have looked at ECG and 2 in echo, apart from the studies that I've been involved in. We move over to East Asia, it's a bit better, with 6 looking at ECG and 7 looking at echo. When we look at those studies that have looked at Pacific Islanders in particular, there's only 2 studies. And similarly, studies within Africa, there's only been 2 studies as well. So more research really does need to be done to try and elucidate these findings and try and get a better understanding of geographical origin on interpreting the athlete's heart. When we move on to sex, we see that the participation, thankfully, has increased significantly from the not the London Olympics, Paris Olympics of 1990, compared to, well, what would have been 2020 Tokyo Olympics, hopefully 2021, fingers crossed, but that female athletes are constituting 48.8% of participation. This has not, however, sadly translated to athletes' heart research. Indeed, in this review recently, they highlighted the fact that a surprisingly low number of sports cardiology studies have been conducted on females. So more needs to be done on here. In particular, because when looking at when reviewing athletes' heart research in females, this study is really one of the few that have looked at it in isolation. They ultimately showed that female athletes have fewer training-related ECG findings when compared to males. Antonio Pellicci's study from, I think, the 1990s showed that, in fact, males have more abnormal ECG findings than females. But ultimately, the 2 studies from Maria Brosnan and Megan Wasfi that I showed before, they showed similar prevalences of abnormal findings among their endurance athletes. Similarly, the study from Sharma's group have shown, again, similar findings. But the only finding really where females had a higher prevalence was that of anterior T-rib inversion. This was predominantly isoelectric, but important to note that this was not really related to athletic training. This is just a sex-specific finding. But ultimately, should we be interpreting the athlete's ECG differently based on sex? Well, of course, QTC is important, and within the guidelines, this is the only criteria that is said to be considered. And that's ultimately because during puberty, testosterone levels in males result in a decrease in the QTC interval. When testosterone levels decrease later in life, the QTC seems to increase as well. And there may be an impact of estrogen on these findings as well. When we move over to the structure of the female heart, then we see that compared to the recommendations and American Society of Echocardiography guidelines, 8% are suggested to have a wall thickness exceeding the normal limits. When compared to males, we see that even after supposedly accounting for body size, wall thicknesses were still higher in males, irrespective of, in athletes in the same sport. With regards to cavity, similarly, 7 and 8% had a finding over and in excess of the upper limits within the general population. This time, however, compared to males, females had a larger cavity size when supposedly accounting for body surface area. Body size is an incredibly important thing to be considering, though, when looking at the athlete's heart. And again, it goes back to the fact that that previous study accounted for body size using body surface area. But these two athletes have the same body surface area. And we know that left ventricular mass is correlated not necessarily to weight, but to muscularity. And so, we may erroneously be categorizing athletes beyond or below upper normal limits wrongly based on body size. Indeed, still, however, the guidelines suggest the use of scaling cardiac data to body size using a ratiometric approach. We know, however, this is incredibly flawed, indeed theoretically and empirically flawed, and even the authors in 1949 highlighted that these findings may lead to misleading results. It's frustrating because even in the guidelines, they acknowledge the fact that the way accounting for body size is done is wrong, but just the fact that most large population studies report LV mass divided by body surface area. So that's just the way it's done. But it is wrong. And we know that because of the differences between geometry. When we are comparing a left ventricular mass, which is a three-dimensional entity, divided by a two-dimensional body surface area, can we really compare? Well, that suggests that there's a linear relationship. And we know that these do not compute on a linear relation. They're in fact curvilinear. And it's shown nicely within this study that compared male and female athletes that were matched for age, ethnicity, and sport, and indeed, LV mass to body surface area had a high correlation. But when accounting for lean body mass, a three-dimensional entity, it was normalized, and gender did not in fact emerge as an independent correlate for left ventricular mass, suggesting that sex is not necessarily an important factor once accounting for body size, in particular fat-free mass, which we know is more metabolically active, so therefore correlating more nicely with left ventricular mass. Indeed, the same study shows that using body surface area as the scaling component, there may be a 20 to 30% difference with body surface area. Importantly, the recommendation suggests that there may be a 20% difference in male cardiac size to female cardiac size. So ultimately, it may not be due to sex, but just to body surface area. And it's also important when comparing not only the longitudinal development of athletes, but intra and intergroup comparisons, for example, a jockey and a basketball player, and also the establishment of upper normal limits. Again, we looked at this in whether the biggest athletes do have the biggest hearts. And we looked at 100 athletes with a body surface area of over 2.3 meters squared. And these are big guys. And we found that those with a left ventricular wall thickness of over 12 millimeters was indeed highly correlated to body size. But actually, only 12% had a wall thickness of over 12 millimeters. No athlete had a wall thickness of over 13 millimeters. And we ultimately suggested that the upper limit may just be 14 millimeters, and there may be in this kind of plateauing of cardiac size to body size. However, different results were shown in basketball players, and they showed 12% of their basketball players had a wall thickness of over 13 millimeters. And again, body size having a particular influence. When we look at cavity size, we see a high correlation between body surface area and height compared to internal diameter. Indeed, 37% nearly of these athletes showed a cavity size of over 60 millimeters, getting onto the physiological pathological grey zone. However, while this compares to 14% within an Antonio Palicia study of a general cohort of athletes. However, in the basketball players, when accounting for body size, no athlete showed a value outside the normal limits, highlighting again the importance of body size. Antonio Palicia showed it nicely, while highlighting that 50% of the variance within left ventricular cavity was due to body size. So we really need to do a better job in all athlete heart research in accounting for body size, not only using ideally fat-free mass as the body size component. It's difficult because the only way is using DEXA or skin folds, but also the scaling approach. We have to be doing it by allometric scaling and getting rid of this ratiometric scaling because of the relationship between body size and cardiac size. I move on to age now. And age is another one where the definition also shows differences in how we should be reporting youth athletes. You know, whether we are looking at a child, a pediatric athlete, are they adolescent or just young? The only kind of recommendations that have looked at pediatric athletes within the context of cardiac screening have been these. However, even among this, they somehow don't give a definition of what a pediatric individual is. They also don't give any recommendations on any differences between pediatric athletes and adolescent athletes. And this is confounded when we look at the age of screening, age of start of screening among the different organizations, you know, from 8 all the way up to 16. And we have to be thinking, what are we looking for at young ages like this? Are we looking for cardiac remodeling? Does it indeed even occur at the age of 8 or at 12? Ultimately, we know that young athletes do train quite significantly. This Premier League Academy showed that young athletes were training almost 7-8 times a week. And while we don't have training intensity data here, it's something to consider that these are mini athletes, mini adult athletes, I guess. And it's probably no surprise, therefore, that there are increases in left ventricular wall thickness among athletes compared to controls. And again, it goes back to the study I mentioned at the very start, which looked at athletes in Norway and showed that young athletes did have concentric remodeling in and above controls, even as young as 12 years old. In this study, up to 5% had a wall thickness above the normal limit. Only 0.4% of them had a wall thickness of over 12 millimeters, I think. Suggesting that there is not that level of cardiac adaptation at a young age, but in comparison to controls, there most definitely is. Within females, there was no athlete that had a wall thickness of over 11 millimeters, suggesting that that should be the upper limit. And in males, the upper limit of wall thickness should be 12. When looking at internal diameter, the meta-analysis that we did, we looked at athletes versus non-athletes, showing a significant finding here. Those over 14 versus those under 14, again, significant findings, but no significant findings between males and females, corroborating what we found in the adult athlete. However, among this, all the studies within this meta-analysis, only a third actually accounted for maturation. And we know maturation is incredibly important. We see it when we looked at a study ourselves, looked at this athlete that had a chronological age of 9 years old, but two very different biological ages. And we see this on the ECG. We noticed that chronological age is not a predictor of anterior T-wave inversion or the juvenile pattern that is often seen among young individuals. Biological age, however, was a significant influencer and predictor of anterior T-wave inversion. This is important because ultimately sensitivity of the ECG criteria using biological maturation is significantly higher, meaning when we use biological age as opposed to chronological age, we have a better chance of identifying pathology, which is what it's all about. It's important as well because the ECG criteria use the definition of 16 years old as a chronological age as the differentiator between what should be considered a normal finding and what should be considered an abnormal finding. So again, age has a significant impact on how the athlete's heart remodels. But ultimately, that is the end of my talk. The conclusion ultimately is I want to highlight the fact that type of sport is important, but more important is the training volume and intensity. Also, body size really has a significant influence on cardiac development, and we also must be accounting for this better. That's it. Obrigado. Thank you very much.
Oh, dear Nathan, thank you very much for a beautiful, beautiful lecture. There are some things that caught my attention, and this is very nice to say. The lecturer showed his job. In other words, Nathan with the Sanjay group, sometimes with André Legerge, sometimes with Aaron Bagish, and with the group that is in our international symposium. What I would like to say is that fresh data and former data from Nathan and some of his partners from UK and from Australia, André Legerge, was shown to us. And this is very, very, very nice to see. Nathan, there is something, if I can't record the question and answer section, the YouTube will not be able to see this part of the symposium. May I ask you from my heart that you let us to record some few questions? Only 14 minutes.
Okay.
Thank you very much for your understanding. Thanks a lot. And later I will excuse you. We will excuse myself with you personally for this. But I think it will not be a problem. I have some questions for you from me and from the audience. And the first one is you presented us the Seattle criteria, the international criteria, and the international criteria we were together in Seattle with a group led by Jonathan Dresner, and you had shown some papers from Jonathan Dresner as well. We made, I think, a beautiful job. But international criteria would be the ultimate paper in this area of knowledge, or we just need in 2020 another international criteria?
That is a very good question. Thankfully, I guess research is always evolving. And so I think at the moment, the studies that I've shown, it's only been our research that has done this. So when I say, for example, with the adolescent athlete and the chronological and biological differences within the interpretation of anterior T-wave inversion, for example, we're in a very fortunate position where we were able to do wrist x-rays on all the athletes. I mean, in normal clinical practice, you can't do that. Unless you've got a lot of money. And so it makes it difficult to be able to assess biological age. And this is ultimately the thing that will govern what happens in practice. Of course, more research, I feel like it's always more research needs to be done, but more research does need to be done to try and support these findings that maybe biological age is the governing factor here. But in terms of widespread recommendation for clinical use, then I think that would be difficult.
So, summarizing, it's time to Jonathan Dresner to invite us again to Seattle.
I would love to get away from Qatar.
next year.
Next year, if we can fly away, that would be fantastic. Yeah.
I would like to say that to the audience that we are taking care. I am not wearing masks, but Juliana de Lima, Thais, Beuren, and Ozzy are with me here. They are wearing masks, and we are with a physical distance, respecting this moment that is not an easy one, even in Qatar, and in Brazil as well. Another question for you. Let's say soccer, football is a very important sport here, as it is in Qatar, and the next World Cup will be hosted in Qatar. Do you think that the positions in football, for example, matters? The goalie and the middle field, what do you think about that?
Of course, yeah. And I think, like, in the presentation I did, I was saying Andre Lagersh's name and Aaron Bagash's name all the time, because they've been seemingly hammering on about this point that the definition of an athlete cannot simply be type of sport. The Americans have done quite a nice job at looking at position in American football. And of course it matters. It matters in the training that you do. I don't know, a central midfielder may do more resistance training than a winger, for example. And so simply by saying type of sport elicits this type of cardiac remodeling is wrong. And of course, intensity of how we train really does govern cardiac remodeling as well. So position likely would have an impact, maybe in football, soccer, not as much as I would imagine in other sports where there are incredible differences between position. But for sure, yeah, it all depends on training intensity and volume, yeah.
I would like to incentive people to make questions. Thais is here to send me the questions that the audience would like to make. But since I didn't receive any question, I will ask you some things. And Nathan, what about steroids and the heart? We know that this is a very important issue, important and something that could harm the heart. Can you talk a little bit about this?
Sure. So, I mean, it's not an area that I've particularly looked at myself, but of course, it does have a significant impact on, the concentricity of the heart. And it does seem to affect the heart in a more, a different way than physiological remodeling would. And it's important because, when we're looking at bodybuilders and things like that, they do a different type of training. And just in terms of the stimulus of what anabolic agents do does cause more concentric remodeling. And I think also, I may be wrong in this, like I said, I'm not an expert, but it affects the blood pressure profile as well, I would imagine, which again has been strongly linked to, concentricity. Certainly exercise-induced hypertension has been shown to affect concentricity of the heart,
Can bradycardia be a problem in an athlete?
So I know that you have done quite a few papers on bradycardia and effectively what governs it, right? So in terms of autonomic influences or potentially even stretching of the heart can cause differences within the SA node. And so, yeah, for sure, like we present all the time, most athletes have bradycardia. And with bradycardia, the definition of just anything under 60, it's really, too broad of a definition. When we're getting down to the 30s, that's when it starts getting interesting, right? Ultimately, it's related to the sick sinus syndrome. And that's I guess, the alternative diagnosis when you get a heart rate below 30. But still, anything over 30 in an athlete has been shown to be normal. And again, like you said, whether it has a reasoning behind it of vagatonia or whether it has other factors, then obviously you will be able to answer that much better than I would. Yeah.
No. I answered to you. I asked it to you just to learn a little bit more. Another thing, the U curve. If you are an inactive person, you are at risk. If you are a super hyper giga athlete, what do you think about this? Training 7 times per week or 14 times per week for a triathlon, Ironman, whatever. Yeah. What do you think about this?
Well, for sure, like there's been the studies on the Tour de France cyclists and just how much the cavity dilatation is in comparison to even like other sports where you may expect to see it more, such as the basketball players. In the cyclists, they had larger cavities than actually the basketball players that were 200 centimeters tall and 100 kilograms. And of course, I can only presume that Andre and Aaron are going to talk about this in more detail. But the right ventricle is, of course, has Perfect. A significantly increased wall stress than
and the next lecture is an expert about right ventricle. Andre Lagersh have done a lot of studies, and he's a right ventricle lover, isn't it, Andre? He's waiting for us. I have a question here. What about? Let me check here. What about the training to determine physiological versus pathological remodeling? Is it useful? Fernando Pivato is asking.
For sure. I mean, in terms of wall thickening, it's been shown to reduce, of course, following detraining, and may go some way to elucidating the findings between physiology and pathology, and kind of because we know that sport induces left ventricular wall thickening, that by reducing this stimulus, it may remove that effect and kind of uncover what could be the more pathological expose of remodeling. With regards to cavity dilatation, I think, I don't know if it's the Italians have shown it, but ultimately that cavity dilatation doesn't necessarily decrease following retirement or stopping of sport. And this may go some way to explain atrial fibrillation and things like that in endurance athletes. So while the left ventricle wall thickening may decrease following the termination of sport, the cavity dilatation in some athletes may remain higher. Yeah.
Mm-hmm. So I have my last question for you. There is another one. Recently, a young Colombian midfield under 20 football player died on the field with no family heart risk or heart disease. How important is the pre-participation screening in junior sports like this? I don't know the name. I don't know the name of the person who Miguel Cardena asked.
Okay. So yeah, I mean the incidence of sudden cardiac death is high among adolescent athletes, and that we know that the athletic remodeling that we see is elicited in adolescents. You know, like I said, they are training a lot, and so with regards to cardiac screening, of course it is important, and determining the initiation of cardiac screening is a more, I guess, difficult question, whether it should be like the Italians of 8, or, you know, in England, every athlete has to have cardiac screening, I think from 14, I think it was. And so determining the start of cardiac screening is difficult. But of course it has its uses, you know. We know that it is able to identify this cardiac remodeling. Of course, yeah. In terms of should we screen or not, then that's for another day, I think.
I think that this question enables me to make a propaganda of Lorenzo Montserrat Iglesias lecture on October 31st about genetics and sports.
There we go. Sorry.
It will be interesting as well. So it's 9:59 right now. It probably is almost 4 o'clock in Doha. Am I right?
You are correct.
Correct.
Yeah.
Okay.
A bit earlier than what it is in Australia, thankfully.
No, Australia is almost midnight, and this is why I will thank you very, very much for your participation. You told me that you were a little bit nervous. I am nervous. You were perfect. Or
I know, of course.
Your control is fantastic, because your lecture was just like this. Incredible. Thank you very much.
Richard.
No. I think everybody who was watching it, and the people who will see it later really will like the opportunity to listen and have an idea and learn exactly about you are doing, and some other people who will participate in this symposium are doing as well. Sandra, in my name and in your name and name of all of us who are working in this symposium, we would like to thank you a lot, and invite you to stay with us if you can.
For sure. Obrigado.
Obrigado. Salam. Thanks very much. And now we will have a few minutes, and Andre Lagersh will be with us in very, very soon. Okay? Bye, Nathan. See you.
Thank you very much. Bye. Thank you.
you should go below in the screen, and there is a share screen.
Yeah, present now.
Present now. Good. All right. Thanks.
Okay. No, okay. I will. Can I? Okay. After Nathan reading excellent lecture, I would like to introduce a good friend from Australia. We travel from Qatar to Australia right now, and Professor Andrew Lagersh is with us at midnight in Melbourne. Actually, is 25th over there. Andrew Lagersh is an associate professor at University of Melbourne, head of clinical research domain at Baker Heart and Diabetes Institute, a cardiologist at St. Vincent's Hospital, Melbourne, and a person who studies a lot the heart, image of the heart, the right ventricle, and he is very, very keen in the arrhythmia, the fleet arrhythmia area. Andre, be my guest, and in the next 30, 35, 40 minutes, we will be with you listening your talk. Please.
Okay. Thank you, Ricardo. Can you hear me and can you see my slides?
Fantastic, yes.
Okay. And can you also see me?
Yes, this is the problem, but we can see you.
I was going to say it is a problem. So to introduce things a little bit, not only is it the Australian Grand Final, but also we're very much in lockdown from COVID, and we can't even visit the hairdresser. So I can't wait to have a haircut. But anyway, let me get to the point of the topic, and thank you very much for having me. It's a very nice lecture series, and yeah, I'll be chatting about the whether or not athletes are at increased risk of arrhythmias. So let me get underway. I mean, this is a nice segue that I heard, asking some of the questions to Nathan about a U-shaped curve. But it's well established that there is an asymptote of benefit, or at least as you become fitter, the risk of cardiovascular events, and in fact, the risk of dying, the overall mortality.
Andrew, sorry, there is an interference, a small interference. Can you try to fix this for us, please?
Ooh, how do I do that? I'm a bit worried that maybe my internet connection is not good.
Now is great. Now is great.
Okay, are you sure? All right. So there's there's reduced cardiovascular events as you become fitter. The question is whether or not in the sort of levels of super fitness, whether the risk of cardiovascular events may increase again. And this idea that you can do too much exercise, and corresponds with the sort of ranges of exercise where you also see really remarkable remodeling. Here's the heart of an average fitness and a super athlete blowing up so they're at the same scale, and you can clearly see the athlete's heart being twice as large. So how safe is that? Now, to provide some context right up from straight up front, is that even amongst those people doing massive amounts of exercise, the outcomes are very good. So this is data from over 15,000 Olympic athletes, in fact, Olympic medalists, and it shows that people who win gold medals seem to have even better survival than those who win silver medals and bronze medals, and those doing endurance more than mixed than power athletes. So this would suggest that endurance athletes do very well indeed. And some kind of almost humorous but quite informative anecdotal information. Barry Merrin and Paul Thompson put together the data on the first 20 people to run under 4 minutes for the mile. And if you look at the age of the athletes at which they either died or are still living, they're well beyond what would be expected for someone matched in their population. So athletes certainly live well. They live longer, and This is sort of a cartoon summarising some data suggesting that overall athletes live longer. Most of that is due to reduced vascular events, fewer heart attacks, fewer strokes. But there is this sting of the tail, which is the point of this topic, which is that that there is an increase in the risk of arrhythmias. Now, Ricardo, I'm hoping that my internet connection is okay at this stage.
There is a small interference, but I think everybody can understand you. Let's say your voice is different. Okay.
Okay, maybe that was from yelling at the football. So, a bit of a cartoon of where I'm headed. Atrial fibrillation is, and I'll go into this in some detail, atrial fibrillation is more common amongst athletes. Atrial flutter is more common. There's an increased prevalence of heart block, advanced heart block, and even the use of pacemakers in athletes. There's very high rates of ventricular ectopy, even a suggestion that perhaps ventricular tachycardia is more common amongst athletes. But as we go from atrial fibrillation, which is a common disorder, through to things like ventricular tachycardia, it's very hard to prove whether or not they're more common in athletes, given how uncommon they are in the population. So atrial fibrillation is really quite a clearly established U-shaped curve where, as you go from being sedentary through to average fitness, there's a clear reduction in atrial fibrillation. But intriguingly, from moderate fitness through to very high fitness through to super fitness, there's an increase in the prevalence of atrial fibrillation. So this is one of the most quoted systematic reviews. It summarises a bunch of case control and cohort studies, each of them relatively small and in their own right not particularly strong, but a clear and consistent message coming through that athletes having more atrial fibrillation than non-athletic populations. Then into the big data, and this is a study we put together this year of nearly 500,000 individuals in the UK Biobank, showing again this U-shaped curve with a reduction in atrial fibrillation with more activity, but then this increase, and if we look at vigorous physical activity toward the upper end, we see that the rate of atrial fibrillation increases in males, and you see the same pattern in females, although not reaching significance. Now, it's really important when you look at this to remember that 5,000 minutes per week is still well below, way below the range that we would see in for example, a competitive cyclist. So if we extrapolate from these curves, we start to see the 2, 3, 4-fold increase in atrial fibrillation that we see in some of the studies such as this, in which they looked at cross-country skiers in Scandinavia. And the really nice thing about this study is, rather than comparing athletes with non-athletes, they compared, they looked amongst people competing in a long cross-country race and could demonstrate that those who finished fastest and who did the most races were more likely to have atrial fibrillation. In other words, you know, the faster, fitter athletes who had been training for longer were the ones who tended to have atrial fibrillation, even against, if you like, somewhere near the very already very fit. So we got very intrigued in this question and set up a study in 2016, which we called the Pro-AF-Heart study, wanting to look at atrial fibrillation in endurance athletes. And we've now studied 120 ex-Olympic and World Championship rowers aged 45 to 80. The reason we chose rowers is that in Australia, the rowing community keep a very good database of who has competed, so that we could try to be as complete without a selection bias as possible. And we're sort of preparing the data at the moment, but the prevalence of atrial fibrillation amongst our athletes is really spectacularly high, even higher than the relative risk seen in the cohort studies I described before. But we also wanted to understand what were the characteristics of athletes with atrial fibrillation as compared to non-athletes, and also people with and without atrial fibrillation. So we had a fairly simple design, which was looking at 144 individuals, half of which were elite endurance athletes and half of which were non-athletes, half of which had AF and half of which did not have AF. So there were 4 age and gender matched groups so that we could look at the effects of athleticism and we could look at the effects of atrial fibrillation. And perhaps to some people's surprise, but not really to ourselves, the endurance athletes had larger atria than non-athletes, regardless of whether they had atrial fibrillation. So in fact, the atria in the athletes were larger even than the non-athletes with atrial fibrillation. So whereas atrial size was a discriminator in non-athletes, in athletes they just had universally very large atria. As you can see, volume indexed at mean around 45 mil per metre squared. On the other hand, and I don't know, it's interesting with Nathan's talk, I don't know why we don't scale to other chambers in the heart more frequently, because we do see very large atria in athletes. But if we make that as a ratio of the ventricle, then in fact they're very normal atrial sizes relative to the ventricles, and like those without AF, and quite different to the non-athletes with atrial fibrillation. I really encourage sort of the use of scaling the LV to the RV, the left atrium to the LV, left atrium to the right atrium. There's a nice internal metric of what is normal within the chest. Now, the other intrigue in this was strain. Strain has been well shown to correlate with, or atrial strain, with atrial fibrillation and also with complications of atrial fibrillation. And in non-athletes, again, we saw lower atrial strain in those with atrial fibrillation, in paroxysmal atrial fibrillation, whereas in athletes, it was low in both groups. To suggest that either all athletes have abnormal atria, or to suggest that, that strain is just not a useful measurement in athletes. Again, not useful as a discriminator as to who has atrial fibrillation or not. If we start getting a little bit sort of cute with the data and make LA contractile strain relative or indexed to left atrial volume, then we can start to see some very small differences in athletes. I'm not proposing that as a particularly useful clinical index. Now, if we move away from atrial fibrillation with the conclusion that it's more common and associated with larger atria that with lower deformation measures, the thing that becomes really controversial with regard to arrhythmias in athletes is whether the life-threatening arrhythmias are more common. And the pictures that I have on the screen here are a handful of athletes in Australia and New Zealand that have very famously had cardiac events and have had defibrillators implanted. And it really, we frequently have this question raised by anecdote and by small series. Now, just to kind of illustrate the point here, using an example. So this is I've always found this quite an intriguing little anecdotal story. So this was a very famous international marathon runner who died suddenly during a marathon. And the autopsy report showed a very large heart, approximately double the normal weight, with patchy fibrosis and with moderate right ventricular and right atrial dilation as the sort of standout feature. Now, the end was sort of nominated as natural causes. To me, that's an almost perfect description of exercise-induced cardiomyopathy. The other thing that was interesting about this case was that when the person had an echocardiogram 8 years prior to having an arrest and dying during this marathon, he had an echo where the reporting cardiologist wrote that they have a very large heart, likely an athletic heart. And the next line I find intriguing and really underpins pretty much everything I do, saying, "I will pursue further research as this seems to be far on the extreme of an athletic heart. The LV function is, however, excellent. But this question, how big is too big, or are there any prognostic implications of having a very large heart, is something that I've been studying and something that I'm not convinced that anyone knows the answer to. These are the sort of hearts I'm talking about. 30 beats per minute, really very large, 70 millimeters by diameter, volumes over 300 mils, extremely large hearts. Now, we studied a group of athletes before and after endurance sporting activities, ranging from a marathon, sort of at average, our participants finished in 3 hours, through to an Ironman triathlon, average finishing time of 11 hours. And the striking feature in these studies is that we can see a sort of cardiac fatigue, cardiac damage, if you like, with increases in troponin and B-type natriuretic peptide. But the really standout thing is that the right ventricle frequently is not working at the end of the race. And here we can see, using right ventricular ejection fraction, that the longer the race, the more right ventricular dysfunction that we see. And you can clearly see in this athlete after the race really quite severe right ventricular dysfunction. And at a similar time, or a few years earlier, my colleague, who I subsequently worked with for a number of years, Hein Heidbuchel, had described amongst European cyclists the finding that when athletes presented with ventricular tachycardia, it was frequently associated with right ventricular abnormalities and arrhythmias that mostly came from the right ventricle, and that it was not benign. In their 46 athletes, nearly half of them had a major arrhythmic event in the subsequent 5 years, and nearly a quarter of them either died or had an aborted sudden cardiac death. So this led us to this kind of concept, putting the two studies together, that if people did really extreme exercise, and if they did it frequently enough, you could get some sort of overtraining, fibrosis, and that this could be a substrate for arrhythmias. This idea of exercise-induced arrhythmogenic right ventricular cardiomyopathy. And we thought that it was exercise-induced and different to familial arrhythmogenic right ventricular cardiomyopathy, because we just could not find any family history. So this is an example in one of our Australian athletes who had some right ventricular arrhythmias and retired from cycling in 2011 for nearly 2 years, and then returned to high-level training. And you can see the really quite marked remodeling from when he was retired through to returning to sport, with a big right ventricle, flattened septum, and this sort of bulging appearance of the right ventricle. And he actually arrested at the national championships, fortunately, has done very well. But if we look at these people using genetic testing, then we fail to find a genetic cause. So in only 12% of the athletes, of the 47 athletes that we studied who met criteria either completely or in part for arrhythmogenic right ventricular cardiomyopathy, in only 12% did we find any abnormalities that were even vaguely suggestive, variants of uncertain significance and the like. And even those that we found have subsequently mostly been found to be benign variants. Subsequently, the group in Baltimore of Hugh Calkins have basically shown exactly the same thing, which is that those people who have an ARVC-like phenotype and are athletes tend not to have genetic abnormalities. And those people who tend to have genetic abnormalities tend not to be athletes or tend to have lesser amounts of exercise. So this suggestion that it's sort of acquired rather than genetic, or indeed introducing the concept of sort of environmental genetic interaction, so that you can have bad genes, you can have lots of exercise, or you can have kind of a combination of both. And that concept that exercise can bring ARVC on earlier has been demonstrated again by the Hugh Calkins group, and in fact by in really a number of studies now, and is well proven. So So the question that we wanted to know, because athletes don't care, you know, if you say to them arrhythmogenic right ventricular cardiomyopathy, they say, what the hell did you just say? They just want to know whether they're safe. And the challenge for us is when an athlete presents with ectopics or presents with palpitations, we need to work out whether they're part of the majority of athletes that have benign ectopics and nothing to worry about, or the athletes that we've estimated around somewhere between 1 in 1,000, 1 in 5,000 athletes who may have a life-threatening arrhythmia. Now, we can look at things like, is there fibrosis within the heart, and our cells, and in fact, several studies now have shown small patches of fibrosis within the heart, but usually associated with very benign outcomes. The other thing that we started to focus on was whether we could differentiate between hearts that had a problem and those that were healthy using exercise. So we used this exercise MRI to stress the heart, and then we could look at the volumes very accurately. And what we could show is that those athletes who had serious arrhythmias, like those endurance studies, their right ventricular ejection fraction did not augment with exercise. So here's healthy endurance athletes in green, and athletes in blue, and in red athletes with serious arrhythmias, and their right ventricle didn't work. Whereas the left ventricle was all very similar amongst those athletes. And this is quite easy to demonstrate. Here's two athletes, one who's healthy and one who has life-threatening arrhythmias, and they both look very, very similar. Whereas with exercise, the healthy athlete has good augmentation of the right ventricle and the left ventricle, and in the athlete with arrhythmias, the left ventricle is contracting okay, but the right ventricle actually dilates and functions no better at all. The ejection fraction 57 and 57. Now, that's not the only story. We thought that perhaps right ventricle, that exercise-induced arrhythmias in athletes were all due to right ventricular problems, and in some ways were a sort of subtle right ventricular cardiomyopathy. But subsequently, other abnormalities have been associated with arrhythmias in endurance athletes. Domenico Corrado produced a study in circulation electrophysiology, and Frederick Schnell in British Journal of Sports Medicine, both showing a similar thing, which is these patches of epicardial enhancement, often of the left ventricular apicolateral wall, not universally, but mostly in that region, that were associated with serious ventricular arrhythmias. And in a really very elegant paper by Katja Zeppenfield in the Netherlands, demonstrated that in athletes presenting, a little bit like our own experience, but athletes presenting with right ventricular arrhythmias, it was often due to quite extensive epicardial scar around the outflow tract, but often extending over quite a large area. And that unlike right ventricular outflow tract tachycardia in non-athletes, this could promote very rapid and potentially life-threatening arrhythmias. So as a kind of summary, in a paper that will be, or an editorial will be coming out just in the next few weeks, I think that the concept of exercise-induced ventricular tachycardia or exercise-induced arrhythmogenic cardiomyopathy in athletes needs to be expanded, not just for those people with sort of right ventricular abnormalities and reduced right ventricular function, but also this concept of outflow tract, epicardial scar, and also left ventricular apical scar. So very much like ARVC, that is now called arrhythmogenic cardiomyopathy because we started to recognize a broader range of expressions, left ventricular involvement, left ventricular dominant, etc. I think that we're seeing a similar concept in athletes. What this means clinically to me is that when I see an athlete with palpitations who's an endurance athlete, I take it more seriously than in non-athletes, and really quite thoroughly assess those people, starting with assessment of rhythms with Holter monitors, etc., and then expanding into various forms of imaging, MRI, sometimes even PET scanning, electrophysiological studies and exercise imaging, depending on the clinical situation. This is an example of an intriguing sort of 44-year-old Ironman age group champion who said that when he ran along, he would suddenly feel like his legs went all like lactic acid and heavy, and it would happen like a click of the fingers. And when we did exercise testing, he would just go in and out of ventricular tachycardia, and with various different focuses, really quite a complex and ugly looking ventricular tachycardia. And this is his heart already. You can see the right ventricle looks a little bit odd. And in Hartsman, he has exactly what I described before with this sort of epicardial, apical-based scar. And when we did some exercise imaging, you can see that where the scar is, the left ventricle is really not working at all. And similarly, most of the apical part of the right ventricle is not augmenting. So essentially this idea that arrhythmogenic cardiomyopathy in athletes can manifest in different ways, and that exercise can be a very, combined with scar imaging, can be a very useful way of assessing things. Coming back to this concept of environmental genetic interaction, I think this is the thing for the future, is trying to understand why amongst 5,000 athletes, one or two of them develop a problem. Is it because they train differently? I mean, we see hundreds of endurance athletes in different sports that train incredibly hard, and still it's only a minority that run into problems. Is it dietary? Is it that they've had intercurrent illness? Or is it that they have an underlying genetic predisposition or a polygenic predisposition that puts them at risk? So to assess that, we've been running a study in collaboration with Belgium, which we call the Pro at Heart Prospective Athletic Heart Study, in which we are taking young elite athletes aged 16 to 23 and following them over 5, 10, 20 years to try to work out whether there's any problem with these long-term, high-level exercise. But also we're taking genetic samples to see if there's any association between genetics and then subsequent risk of arrhythmias. So in conclusion, extreme endurance exercise, I'm absolutely convinced, is associated with an increase in some cardiac arrhythmias, certainly atrial fibrillation. And I'm not sure whether it is atrial fibrillation. I am not sure whether it's atrial fibrillation alone, or whether athletic conditioning in some people results in a electrically irritable or arrhythmogenic heart more broadly, and that atrial fibrillation, being the most common arrhythmia, is the one that we pick up. I think that's yet to be sorted out. The question also for the future is how much of this is due to exercise alone versus genetic predisposition or other things like illness and even performance enhancing drugs that was mentioned earlier. And I think that the really key answers from this are going to come from larger prospective studies. And it's really only then that we're going to be able to accurately define the extent of the risk, which I think is very small in endurance athletes, and also more clearly define predisposing factors so that we can identify those athletes that we need to watch more carefully or even intervene upon. And with that, thank you very much.
Andrea, thank you very, very much for your talk. I think that the audience realize how nice is the opening to lectures of this symposium, and Andrew and Nathan gave us really very, very interesting and important information that Andrew, I was telling Nathan that you are people who are doing science, besides the fact that you are a doctor, a physician, you are on call right now, you are returning to the hospital in few minutes. So for me and for our group here in Hospital de Clínicas de Porto Alegre, na Universidade Federal do Rio Grande do Sul, we are very thankful for your participation. This is something that just a friend can do, and thank you very much for my heart. Besides saying this, I would like to remember that I am not wearing mask because I am in a physical distance from my colleagues here who are working with us in the organization of the symposium. The rest of us are distant and wearing masks. So this is important to say. And I would like to ask you a question, Andrew. As a physician, not a scientist, but as a physician, you have a patient, and this patient is an athlete. This athlete has an atrial arrhythmia, and this atrial arrhythmia is prone to be ablated, is able to be ablated. Do you indicate ablation for all of these athletes?
So, regarding atrial fibrillation, I'm finding that athletes often present quite early with symptomatic atrial fibrillation, and so I tend to, if they've had one or two episodes, I like to see what happens, because we don't have good tools that tell us whether they're going to be one of those people who has a rapid course to a lot of atrial fibrillation, or whether their next episode of atrial fibrillation is going to be in 5-10 years. And I wouldn't like to do a pulmonary vein isolation in it's not going to have any atrial fibrillation for the next 10 years. So my first management thing is to see how things go. I also, in that first period of time, I don't tell them to stop exercising. I tell them that exercise is clearly associated with atrial fibrillation, but we don't know whether stopping exercise makes a difference. However, if atrial fibrillation becomes more of a problem, then I do suggest to them more strongly that they might consider cutting back on exercise. But if they do have more atrial fibrillation, you're faced with the option of medications or pulmonary vein isolation. And in athletes who often are, find myself going to pulmonary vein isolation at an early stage. I often use a sort of flecainide with beta blocker in the pocket, 50 milligrams of metoprolol followed 15-20 minutes later by 200 milligrams of flecainide, for example. But it's not fantastically efficacious, and before long, athletes are coming back and saying, what can you do? So, pulmonary vein isolation is often used early, and the efficacy of pulmonary vein isolation in athletes is as good as non-athletes. It works despite the fact that on average, they have bigger atria, which is a fact for worse outcomes, but in athletes, they do well.
Andrew, another question from myself. There is a true tsunami of physicians asking for cardiac resonance here in Brazil. Maybe it happens all over. And sometimes we have been in front of a late enhancement. What do you can say about this? Is it an incidentalloma, how we say here, or usually if you have a late enhancement, you should go away, go further?
Yeah, so I think that I know this sounds almost sort of patronizing, but it's really important before you do a test to think, why am I doing this test? And it's so true in athletes, because you do fairly often, and probably more often, find things that you either expect or you don't even know what they mean. You know, delayed enhancement is an example. Little patches of septal enhancement in an athlete. What does it mean? We're now doing more and more mapping. What happens if your T1 mapping time is a little bit outside of normal ranges? In the COVID era, you know, there's a number of publications about variations in mapping or bright pericardium. I think it's really important because these are new modalities. Sometimes things that are part of the normal variation are raising alarms or being overreacted upon. So there's basically two messages. One is, before you do the MRI, think long and hard about what you're expecting to find. And then if you find something that's not what you expected, it doesn't mean ignore it, but put it in context, because otherwise you can start just missing things that are irrelevant. And the second thing I would say, always put it in the context. You know, a lot of these COVID publications, for example, including COVID publications in athletes, you know, make a big fuss about some pericardial enhancement. But we've recently done some studies in athletes that have had COVID, and I think it's really important to do exercise testing and to do Holters, and we don't find anything. So we don't find much. We don't find anything. They've all returned back to sport without a problem. I mean, ours is a small cohort, and that question I think is not completely sorted out. But it just, as we get more and more tools, we can raise more and more questions we don't know what they mean.
Thank you very much. You are showing the audience that you are not just a scientist, you are a clinician as well. And this is very important when we are dealing with patients. There are some questions here. Sergio Decker, he's asking, how should the recovery period be to avoid right ventricle cardiomyopathy?
Yeah, so it's a good question. So it's a really good question. So there's two parts to that. One, is there sort of sensible training that can prevent you ever developing the problem? And the second is, if you develop it, is there something you can do? And I'll start with the second one first, because we're more and more confident, both in Baltimore and our experience in Belgium and in Australia, is if these people stop doing sport, you can often stop the process or even help get some regression. So we've had athletes who have enormous troubles with right ventricular arrhythmias, and with detraining things can settle down. So that's one condition, unlike the AF, but one condition where I really do try to encourage people to cut back on their exercise substantially. In terms of what is a safe amount of exercise to begin with, that's a really hard question. I really don't know what the perfect amount of exercise is. So it's not elite athletes. What I tell the general population when they want to know is that if you do 3-5 hours of moderate or intense exercise a week, you're getting your maximum benefit. Anything you do beyond there, you don't get much or any additional benefit. Doesn't mean you shouldn't do it, but it's for the love of it rather than for your health. Is there a point at which, you know, there's too much? I think that's variable between people. I often say it's a bit like stress fractures. You can't say run 100 kilometres but at 110 a week and you'll get stress fractures. There's clearly individual factors and different things that come into play. And I think that's the case with the heart as well. But if something does develop, then with ventricular arrhythmias, we strongly recommend cutting back.
Okay. And also he's asking, right ventricle branch block is in the ECG, in the 12 lead ECG, is a predictor of, I imagine, a bad outcome?
Well, so incomplete and complete right bundle branch block are probably more common in injury athletes. Aaron Baggish and his team have shown that in rowers, and we've largely seen the same experience as well, at least with incomplete right bundle branch block. And it does seem that there's at least some association with bigger hearts and the degree of incomplete right bundle branch block and and potentially complete. Now, having said that, it does not seem to be a marker of problems, though. So it's not, we have not found any association between right bundle branch block and sort of exercise-induced cardiomyopathy. Yeah. If you see right bundle branch block with some other features like extreme axis, you might start thinking about atrial septal defects and various things, but I wouldn't look at the normal athlete's ECG and worry about incomplete right bundle or right bundle branch block unless there's other abnormal features.
At least in non-athletes, we have done a investigation with the VA database. Jonathan Myers participate in this paper, and we have shown that right and left bundle branch block were not predictor of anything unless the person was ill. Heart failure, coronary artery disease, but we didn't deal with right ventricle cardiomyopathy. There are a lot of questions here, and I will go to Caroline Pimentel. She's asking, how do you deal with an athlete with asymptomatic VPBs on Holter and small fibrosis areas on MRI? Is there a role for EP study in this case?
Yeah, so potentially VPBs are common, and I think that they're one of the most difficult things to manage. I know that seems funny, but there's a few things. So when I see an athlete with ventricular ectopics, the first thing that I look for is where are they coming from, and I get some reassurance if they're coming only from the right ventricular outflow tract. And particularly if there's quite a regular period from the preceding beat to the ectopic, a degree of automaticity, they're all benign sort of features, and rarely does that cause, very rarely does that cause any problems. So that's number one thing. The other thing is in people with a lot of ectopics, I virtually always do an echocardiogram for two reasons. One, because if there is structural heart disease, then the ectopics take on more significance. The other is if you're seeing more than 8 or 10,000 ectopics per day, then there's a risk of tachycardia, ectopic-induced cardiomyopathy. So it's worth having a baseline heart function so that you can just check that their heart function doesn't go off. But particularly if there's ectopics coming from an unusual position, or if there's ectopics coming from multiple sites, then I do start to think about things like exercise-induced cardiomyopathy. And in that setting, I think an electrophysiological study and an MRI are extremely valuable. And in fact, the question I ask, what do I do if there's ectopics in little areas of fibrosis, then almost always in that case, I would recommend an electrophysiological study.
Okay, interesting that you are saying, and you showed in the lecture, the term exercise-induced cardiomyopathy. And in 2003, you have shown the paper from Heidenbuchel. Some people, they are saying that there is no, it's not an exercise-induced cardiomyopathy. There is a substrate that is the expression of the disease it's happening because you are exercising. Can you talk a little bit about this?
Yeah, so exactly, there's two sort of extremes. One is that you've got a perfectly normal heart, you do too much exercise, and you damage the heart and you get arrhythmias. The other concept is that you have a heart and there's a problem with it. You have a cardiomyopathy or something, you do some exercise, and that just brings out the problem. And I think there's also something in between, which is that, this is what I was meaning about, if you take 1,000 people and they all do the same amount of exercise, only some of them will get problems. And what we've found is that the athletes who develop problems, we can't find the genetic cardiomyopathy. So in the case of arrhythmogenic right ventricular cardiomyopathy, for example, it looks like ARVC, but then if we look for genetic mutations or ask the family and do a detailed assessment of all first and second degree family members, we just don't find anything. So it's a familial condition, but in athletes it seems that exercise causes it. So that can mean that exercise causes it, or the genetics for athletes are different. Either that it's, you know, polymorphisms, or that it's, you know, let's say a Titan mutation or something that's that. I actually have this very kind of extreme view, which is that I think that you have the genetic makeup, because it's a bit like in Australia we get a lot of melanoma, and the people who get melanoma are people with white skin. If you do a genetic test looking for the risk of melanoma, you don't find the melanoma gene, but we can find the polymorphisms that are associated with fair skin, etc. And I think that the very things that predispose people to have a big compliant heart, that genetic sort of milieu or that genetic combination is good for performance, but simultaneously is a risk further down the track for arrhythmias.
Fantastic.
So it's a bit like the picture I showed of that athlete who had retired and then went back to sport. The amount of remodeling that occurred in just one season of training was so dramatic. And you don't see that in most people. You don't see that ability for the heart to get bigger, stretchier, you know, superb outputs. But that very same heart then has this risk of arrhythmias. It's almost the opposite of what we think of medicine, which is, you know, the sick heart gets arrhythmias. Here it's almost like the best hearts then somehow become predisposed to arrhythmias.
Another question from Miguel Cardenas, I think from Colombia, I imagine. Is the location returning to the subepicardial, subendocardial transmural fibrosis? Is the location of fibrosis important? I think you talk about this.
So there's two things there which are really interesting. So yes, I think it's important, because not just that left ventricular apical sort of epicardial fibrosis, but also more and more we're realizing that for athletes who get right ventricular problems, it's an epicardial or on the surface substrate. And that has implications for electrophysiologists as well, because I've got a number of athletes who have had multiple endocardial ablations that were unsuccessful, and then they went on to the bigger procedure and did an epicardial and found a lot more scar and a much more successful procedure. So for reasons that are not clear, in athletes, often it's a sort of epicardial substrate. I've got a bit of a theory on why that is. I think it might relate to even the sort of friction that comes from rubbing up against the sternum or rubbing against the lungs, a bit like, you know, you can get a rash from your clothing. It's very, very simple thought, but I just wonder about that, because it's just so common that we see this out of the heart substrate of arrhythmias in athletes.
Okay. About cardiopulmonary exercise testing in the COVID era, to assess the performance of the heart and lungs, is it important to test with cardiopulmonary exercise testing after COVID-19 cases for non-professional athletes before restarting exercise? Here we are watching every day top-ranked athletes from our football teams. They got COVID, they rest for 10 days, and in the day 11 they are playing again in the championship in our league. What do you think about this for non-professional athletes first?
So I alluded to this before. My experience is relatively limited, but we studied 16 elite basketballers from one team that all came down with COVID at the same time. They had one of those super spreading sort of outbreaks, and every single member of nearly every member of the team got COVID, and we compared athletes who had COVID with athletes who didn't. We did a CPET, we did a Holter, we did a MRI, we did an echocardiogram, and we really just found nothing at all. So, and you know, it's only 16 athletes, so it hardly tells you everything. But it's interesting because a lot of the recommendations are saying, oh, we should watch these people very carefully. But it's going to be very common that athletes get COVID. And clearly the vast majority of them don't get any symptoms. And my personal view is that what we should do is carefully divide those people who have no symptoms after 10 days. At 10 days, if they feel fine, I'm not sure that we need to do any testing at all. In athletes who have any symptoms at 10 days, from malaise or chest pain or anything like that, then I think we should investigate them. Some people have suggested we should do an ECG and troponin on everyone at 10 days. I think that very quickly becomes unaffordable. Should we be doing that in professional athletes and not your school kid? So I think that we should just be separating. If people feel fine, they can gradually get back into sport, would be my personal view.
Andrea, let's guess together. I know that is probably a difficult answer, but I will make a question. I know from a cardiologist from one team in Brazil, football team, he's dealing with 2 cases, and they are particularly the same. Troponin after COVID is very high, but it's the only phenotypic alteration of these 2 persons who are playing in high-level football here, and they are playing. Let's say, what's your opinion about high troponin levels, normal MRI, normal echo, normal cardiopulmonary exercise testing, normal ECG, normal everything? Just lone bloody troponins are high after COVID. What do you think about this?
Well, so the first very simple practical thing I'd do would be to repeat it with a different assay. And it probably won't be the answer, but I'll tell you why I say that is we had a young rower who came in our Pro at Heart study perfectly well, no problem at all. And her troponin came back at, it was like 6,500 of troponin I. And I called her up and said, whoa, come back. What's going on here? Because we're used to seeing little troponin, but this was high. And we did an MRI, we did it, everything was normal. So then I go back and we repeated the troponin, and it was 7,000 again. Next time, 7,000 again. And then I called up the company and said, what's going on? And they said, we think it's a
kit problem
of the antibodies, and they used a different assay, and it was completely normal. So if it's worth doing, phoning up the company and saying, can you do a troponin T, or can you do a different company assay? Now that's just the odd rare thing, but it's an easy solution. In the people who genuinely have a troponin elevation after COVID, I think we do have to be a bit careful. So I would be watching them pretty carefully, particularly looking for rhythm problems, because that's the thing that's going to be, at the end of the day, would be a sudden serious thing. But I would be following them with imaging as well, especially as we've still got a lot to learn. I mean, things like myopericarditis can be very subtle on MRI, and you can with troponin and not see anything on MRI. So it might be something where you need to sort of just keep following them.
Okay. Does anybody else would like to ask a question to Andrew? He is very tired and need to sleep. Probably I am not your mom, but no, you looked a little bit tired, but even tired, you are a professor, man. Fantastic lecture. I am sure that everybody really enjoy. Thank you very much for doing this for us. A lot of people is watching, these people are watching, and a lot of people will be watching the record lecture. So thanks a lot. And I would like to tell the audience that again we are having the opportunity to see lectures online for free in this morning, afternoon, evening, night, with people who are the people who do science in this area of knowledge. And I forgot, and I will take the opportunity to say that this opportunity that I am having to have you over here is something that I am doing as well to my mentor, Jorge Pinto Ribeiro, who died 7 years ago, and probably he's watching you from the sky. So thanks for this as well. Andrew, we will we'll go to the other lecture in a few minutes, and I would like to again say thanks a lot, man.
Pleasure, Ricardo. You're a true gentleman, and thank you, Sandra. Thank you.
Bye.
Okay, take care. Bye.
Thanks. Hello again, everyone. Now I am with Professor Jonathan Myers. I will call him John because he's more than a professor, and he was my advisor with Victor Fröhlicher when I was in Stanford 2009. Beside this, he became a close friend. We are always meeting around the world. He came to Porto Alegre and to other places in Brazil, giving lectures for us, and much more than this, than John. And Jonathan Myers, beside this, to be a big friend, a close friend, he's clinical professor of medicine at Stanford University in Palo Alto, a health researcher, scientist, and I know how hard he works at the VA Palo Alto healthcare system, and also the director of exercise physiology lab where I worked in VA Palo Alto healthcare system. John will give us the lecture called "The Case for Cardiorespiratory Fitness as a Vital Sign." Signal. This is a question. John, so in the next 30 minutes, please be our guest and share your slides with us, please.
Okay, great. Can you see my slides? I put my slides up on my screen.
Not at all. Maybe
Not yet.
I can't. Probably go below in the screen and share screen in your right side. Maybe, I don't know if it's in Portuguese. Apresentar agora. Right side below.
So let's see.
Put the mouse in the right side. It's written.
Okay, so there is a full screen. Change
Share
layout.
screen. Oh, show below in the screen, in the right, just in your leg. Follow your leg in a straight line. Then you'll see in the screen the apresentar agora. Is it in English or in Portuguese?
In English, it will be present now. In English, it will be present now.
Present
Okay, so
now.
present now, and under present now, I have your entire screen for
Bad luck for you. No hurry.
Okay, so there's entire screen. So I shared the entire screen.
You must click again in share screen. Maybe there is a rectangle share.
So under present now, I have your entire screen. It says present your entire screen, a window, or a Chrome tab. I don't have a share screen option.
Nathan, what you have done in the other side of the screen, you press the...
Yeah, so you press present now, which you did, yeah, and then I presume it's whatever view you would like. So if it's your whole screen that you would like to share, that should be okay.
Thanks, Nathan.
And how is that? Can you see my slides?
No. No problem. So the first step is present now, I think.
Okay, so
your slide should be open in the bar below. The PowerPoint should be in the bar. Then you should click on it. S is the same as Zoom and other platforms. Yeah. Then probably there is a rectangle after present now in the middle of the screen that you should press as well.
Still though.
No. If you want to start again, probably reset. No problem.
let's see. So, Ricardo, there's a present now screen, and I have options. One's your entire screen, one is a window, and one is a Chrome tab.
Mm,
But
Did,
now,
did you test the full screen? Did you test it?
press the full screen, John.
okay, your entire screen, so that's there.
And
So,
your presentation is in the below bar as PowerPoint.
yes.
Okay.
So if I bring up the PowerPoint, then I'll go to present now and I'll present my screen. Now it says when I go you share your entire screen, there's a share
Share. Press on this.
that it doesn't work.
No.
It doesn't allow me to hit that.
Probably you should. Is there a share screen somewhere in the beginning of the process? I will
No,
tell. Sorry, everybody, but this kind of thing happens, and it's something that we are used to experiment because digital road is sometimes tough.
hmm.
Start again and let's do it together, okay?
Okay.
Ele não está
So I'm
conseguindo abrir.
Ricardo, I'm seeing you and the other participants. That's on my screen. There's a present now
Next one.
Okay.
Whenever you want.
Okay, we're all
We'll try. We will
perfect.
work together
Yeah.
again. Please.
That's perfect. Okay, great. Yeah, sorry everyone for the we're a
No.
few delayed, but yeah, Ricardo, just to say thank you and good morning, everyone. I think it's still morning, right, where you are.
Yes.
Appreciate the opportunity to be part of this, and sorry we can't all be together. Ricardo, hopefully I'll visit Brazil again, and and I hope for the health of all of us that time will be sooner than later. Thanks again. And much, Ricardo, you can go to the next slide there. Much of what I'll talk about dovetails off of the work that we and many other groups have done that resulted in this scientific statement from the American Heart Association that was published just a few years ago. And the impetus behind this is the idea that our group and many other groups the last 2 decades or so have shown that fitness is a very, very powerful predictor of risk. In fact, in many of the cohorts, it's more powerful than the traditional risk factors. And we should be treating fitness just like any other vital sign. It should be like blood pressure. Not that we should put everybody on a treadmill who comes in for a clinic visit. That's not the idea, but we should be estimating fitness, or at least talking to our patients and the public about physical activity. So that's kind of the theme here as I go along. So go ahead, Ricardo, to the next slide. I'm just going to review very quickly a little bit of background about the risk factor concept for cardiovascular disease. In 1964, the American Heart Association identified smoking, high blood pressure, and high cholesterol as the so-called primary risk factors for cardiovascular disease. And that resulted from decades of epidemiologic research showing that these 3 things were the things that most importantly underlied were the causes of heart disease. Now, in those days, we didn't talk about lipid subfractions or inflammatory markers or anything like that. It was just high cholesterol. So go ahead, Ricardo, to the next one. And then in 1994, 30 years later, physical inactivity was added as the 4th primary risk factor. Again, and that was based on 3, 4, 5 decades of epidemiologic research showing that if you were physically inactive, you had a greater incidence of heart disease. And then on the next one, 1998, obesity was finally added as a primary risk factor. And now there still remain 5 risk factors. Again, that was a result of decades of epidemiologic research. If you are obese, you had more heart disease, more cardiac events. And also obesity, overweight and obesity were growing across the Western world at that time. So, okay, and the next slide. So, and then the next slide, Ricardo, there just, yeah, so there are secondary risk factors for cardiovascular disease, which include diabetes, family history, age, male gender, race, and stress. And we're in the era of genetic markers as well, and lots of inflammatory markers and biomarkers of cardiovascular disease as well. But these 11 things remain the primary and secondary risk factors for cardiovascular disease. And to the next slide. So the question is, why should fitness be a risk factor? Why should it be a vital sign? I mentioned that fitness is a more powerful predictor of risk than the traditional risk factors. So I'll talk a little bit about that. And then the next one, Ricardo. Why should we encourage our patients and the public to become more physically active? I'll talk a little bit about that. And then the next one. And then I'll talk about this idea that fitness provides risk information beyond the traditional risk factors and show some of the work And this got a lot of attention because it was thought that for the first time, physical inactivity accounted for more deaths globally per year than smoking. And that's because populations were becoming more physically inactive. Smoking has gone down through much of the world, not all countries, but many countries, smoking has gone down. And if you go over to the left here, look at the prevalence of physical activity. Again, it was thought for the first time that inactivity was significantly more prevalent than smoking, again, for the first time. So this was an issue of Lancet devoted entirely to physical inactivity and global health. And then a couple of years later, they dedicated another issue to a follow-up to this. So I'd recommend that reading for anybody who's interested. And I'll go to the next slide there, Ricardo. So there are three statistics that I'll focus on, and for many of you, these may be familiar, for others maybe not, but one is called the population attributable risk. And it's the incidence of disease in a population that would be eliminated if a given risk factor were eliminated. So for example, if we took a large population of people and followed them for 10 or 15 years, and we were to say, let's take out smoking, nobody smoked, for example, would 10% of the population then have survived or not had MIs or whatever it might be? So that's the population attributable risk. And the next slide. So this is a slide, another slide that I've used a lot. I really like this analysis from Steve Blair. It's about 54,000 men and women from the Aerobic Center longitudinal study. And it shows the population attributable risk, or what they're calling at the top there, the attributable fractions as a percent for all-cause deaths. And you can see the usual suspects there along the bottom, and those right 5 columns there: obesity, smoking, hypertension, lipid abnormalities, and diabetes, and the percentages of deaths due to each of those for men and women. But if you go over to the left, low cardiorespiratory fitness, you can see low fitness accounts for more deaths than all of these other more traditional risk factors. In fact, if you combined obesity, lipid abnormalities, and diabetes, combine them together, they wouldn't account for as many deaths as low fitness just alone. So again, something that's not really appreciated by most clinicians or most healthcare providers. Then on the next slide, this is something that we've looked at. This is in press. This is from our, and I'll talk a little bit more as we go along here, the Veterans Exercise Testing Study, or VETS, is what we affectionately call our follow-up, something that Vic Frelicker and I started in the mid and late 1980s. This shows population attributable risks in our population for, again, some of the usual risk factors: hypertension, smoking, diabetes. And you can see over on the left side, low cardiorespiratory fitness, again, accounts for more deaths than these traditional risk factors. And I'll point out that physical inactivity and low fitness together account for more than 1/5 of all deaths in our population. So, and that's really important too. In fact, when we define physical inactivity as just simply not meeting the minimal guidelines on physical activity, which I'll get to in just a moment. But if most people met those minimal guidelines, then they would not be in that low fitness group. So again, that's really important, along with the fact that about 1/5 or over 1/5 of all deaths are due to either low fitness or low physical inactivity. So then Ricardo, on the next slide. So I'll talk now about relative risk. This is probably a statistic that's a little more familiar with most people. It's the probability of an event occurring in one group compared to the probability of an event occurring in another group. And then hit next one, Ricardo. So in our context here, for what we're talking about, it asks the question, what if we compare high-fit subjects with other groups? And then on the next slide, it shows some of this. So this is a pattern. This is a study from a while back that was that we published in the New England Journal of Medicine. But it's a pattern that our group has shown, and many other groups have shown slides or bar graphs like this that are very similar. It looks at quintiles of exercise capacity and the relative risk of all-cause mortality. With the highest fit group over there on the right side, that's the reference group. So that's, you set the reference at 1.0 there. We have those with disease. At the time of their treadmill test, they had known disease of some type in the green bars, and then the normal group in the blue bars there. But what it shows is when you compare the least fit subjects with the highest fit subjects, whether or not you have disease, you have more than 4 times the risk of mortality if you're in that least fit group. And the other thing is, and sorry I don't have my pointer because it's easier to point some of these things out, but you can see a gradient as you go from that least fit group to the highest fit group. There you go, Ricardo, thanks. A progressive gradient. As you become more fit, your mortality is lower. And then something that we and many other groups have seen too, a pattern. If you look especially at the normals and you go from the least fit group to the next least fit group, you cut your risk in half. So getting out of that least fit group, that's where the money is. That's where most of the health benefits occur. Getting the most sedentary or least fit people up and doing a little bit of something has a huge impact epidemiologically. And then the next, click that there. Again, in this study, as we've shown in many others among veterans, exercise capacity is consistently our most powerful predictor of risk. And we see somewhere between a 10 and a 20% reduction in risk per MET. So a small increment in your fitness level or your exercise capacity has a powerful impact on health outcomes, whether we're looking at cardiac events or incidence of various diseases or all-cause mortality. You know, talk about the various chronic diseases in a moment, but go ahead to the next slide there, Ricardo. And this is from our group 2. It shows mortality rate by quintiles of, this time, peak VO2. So we're measuring peak VO2 in thousands of veterans. We followed this group for about 8 years. And in this case, the less than 5 MET group is the reference group over there on the left. Now, 5 METs has been kind of an iconic number to designate a low fit group. We go back to the CAS studies or the coronary artery surgery studies from the late 1970s and early 1980s. Patients who couldn't achieve 5 METs, they were at high risk. It didn't matter whether or not they got bypass surgery. It didn't matter about any other exercise test responses or any comorbidities. They were at high risk. And we've used 5 METs in our country, and this is the case in other countries, as to designate disability and other things. It's kind of the upper limit of daily activities. So if you look at that 5 MET group and you go to just get out of that group, get above 5 METs, you can see your risk is cut in half. And then you go further down to 7 to 9 to 9 to 11 METs, your risk for mortality is lowered further. Note that 11 MET group there on the right side, there were no deaths in this particular 8-year follow-up. And I always like to point out when I show this slide that that can be a little bit misleading because you're not necessarily completely 100% protected. People who are fit, they die also. We all die, right, Ricardo? We're, even us runners and things, we're all going to die someday. But for a given, if we carry the follow-up out longer, we'll have events in that group. But for a given 7-8 year follow-up, they were relatively protected. And it shows the impact of higher fitness and the risk of mortality. So go to the next slide. I mentioned that a small increment in fitness can have a very powerful impact on your risk. Now, this is from a group of colleagues from mine. This was published in JACC a couple of years ago, and it shows an increase in just 1 ml per kg per minute in measured peak VO2 is associated with a decrease in all-cause mortality by 3.4%, cardiovascular mortality by 4.6%, and cancer mortality by 4%. So put that in a little bit different context. We all know if we put a patient in a rehab program or a sedentary person, one of our patients, we encourage them to start an exercise program. It's common to see a 1 MET improvement, or sometimes in 2 METs with a rehab program. That would result in somewhere between 10 and 20% reductions in those outcomes over there, all-cause cardiovascular or cancer mortality. So a small increase in fitness level can have a powerful impact on outcomes. And go ahead to the next slide there, Ricardo. So this is something that's new. It's not published yet. It kind of goes along the same lines as we've been talking about. Peter Kokinos from the Washington, D.C. VA and myself and some others have been working on this for about 5 years. And now this is sort of a little bit of a crowning achievement, I think. We have about 1.5 million exercise tests from across the VAs in the United States. So it's a remarkable body of data. And what we did was we took out all the subjects who had disease, anyone who had a pacemaker, anyone who was stopped for some reason other than maximal exercise and other things. And it shows the deciles of age on the bottom there and the quintiles of fitness. And you can see this pattern again in the numbers there across the top of each quintile. This is about 650,000 subjects now. So we're really happy to get this to this point, and we see that same pattern. Your risk is cut by about 40% if you're under 70 years old, just by going from the least fit to the next least fit group, and 70 to 75% reductions comparing the least fit with the fittest subjects for mortality. If you go over, Ricardo, point over there to the 80 plus group. So those elderly subjects, the gradient is not as dramatic, but you still see these significant reductions in risk as you become more fit, even if you're 80 and 90 years old. So this population is quite large. It's going to give us a chance to really look at some of the nuances, diabetics and obesity. And we've got tens of thousands of subjects who now have been tested serially a couple of years apart. So we're going to look at a lot of different things here in this robust population. Go ahead to the next slide, Ricardo. And then one more point on this. This is one of our studies from a few years back, but it just shows the exercise test responses and traditional risk factors. And up there on the top, exercise capacity. Once again, it's the most powerful predictor of risk, followed by how active you are during your adulthood years, your lifetime recreational activity per week. When we use a 5-page questionnaire on this in a large number of subjects, we show that your fitness level and how active you are. I think I have a pointer there. Hit the next button there, Ricardo. Those two factors are very powerful, even more so than smoking, diabetes, and lipids, and others. And yeah, just one more point on this. The things that we treat with ACE inhibitors and statins and things like that, we treat them often, but we don't treat and we don't counsel patients on physical activity. I'll just make a point there. ST segment depression does not come up to be significant. That surprises our cardiologists. They really like to see that. That sends, when we see ischemia, that sends patients down a sort of sliding down that hole of imaging, and they end up in the cath lab and they end up stented. And so our cardiologists are really focused on that. But again, we don't talk to patients about physical activity or fitness. So go ahead to the next slide there. All right, then why should we encourage our patients and the public to become more physically active? And I've talked about some of the obvious things, but go to the next slide there, Ricardo. I mentioned physical inactivity from that Lancet article is the most prevalent risk factor, but gets the least amount of attention from health professionals. And then the next slide. Most of the Western world is too sedentary. And in fact, that goes now for developing countries, not just the Western world, but it's all over the world. So let me show a few slides on this. You're all familiar with the minimal recommendations for physical activity. They come from health bodies, health organizations all over the world. The World Health Organization, the European Working Group on Prevention and Rehabilitation, Institute of Medicine, The DHSSPS is the UK group. And they all basically have the same, these guidelines, all talk about the fact that all individuals should attempt to accumulate 30 minutes of moderate activity on most, if not all, days of the week. And we hear that more often now as 150 minutes a week, right, of exercise, of walking or something, anything anything that's moderate would qualify. And additional health benefits can be gained through greater amounts of physical activity. And this modest amount has been associated in the epidemiologic studies going back decades. 30 minutes of daily activity most days of the week is associated with somewhere between 20 and 40% reductions in cardiovascular and all-cause morbidity and mortality. So again, a small investment in physical activity yields a very significant health outcome benefit. And then the next slide, Ricardo. We had our United States Department of Health and Human Services physical activity guidelines were released 2 years ago. It was a 10-year update of the guidelines. And it's a 780-page document. Why on earth do we need 800 pages to make this simple message about 150 minutes of physical activity? Well, physical activity has been shown to be beneficial across the spectrum of chronic diseases. And those chronic diseases and the impact of physical activity are reviewed in this document. And we ended up with this 780-page document. In the document, it's estimated that in the US, nearly 117 billion in annual healthcare costs, and 10% of all premature mortality are associated with failure to meet the recommended levels of physical activity. So that 10% figure, that's that population attributable risk that I talked about a moment ago. And go to the next slide there, Ricardo. So they reviewed the literature on this. There's lots and lots of surveys, and I have a whole series of slides on this, but in the 2018 update of the physical activity guidelines, 26% of men, 19% of women, and an astonishing 20% of adolescents meet the recommended guidelines, despite the fact that the recommendations are designed to be achievable by most people. And I think what is most bothersome to me and to many people who read this means that 80% of kids aren't getting adequate exercise. Now, and that's really important. That's changed dramatically from the time when, I was young, when it was the opposite. When I was growing up, I don't know any kids who didn't meet the minimal guidelines. In fact, we were active all the time. It's quite different now. The time we're spending in front of screens and how societies have changed so much. And then on the next slide, Ricardo, I think this is a really a study published last year. It's a really interesting study of 2.5 million adults going back 50, 60 years, a systematic review of trends in cardiorespiratory fitness. And you can see the different countries here where data are available going back to the 60s or the 80s, 70s, 80s, depending on the country, but Canada, Japan, Norway, the United States, but all of these countries show reductions in fitness over the last 40, 50 years. And you can see the one in the lower right there is all of the countries there together, this dramatic decline in fitness. Go ahead to the next slide, Ricardo. So they conclude in this study, there's been a moderate international decline in adult cardiorespiratory fitness since 1980. Declines in fitness were reported across all included countries, with declines generally larger for men than for women, and for young adults than for middle-aged adults. Countries with the largest increases in adult obesity experienced the largest declines in cardiorespiratory fitness. So there you have it. And we have this obesity problem now, as we all know. Go ahead to the next slide, Ricardo. This is a little bit complicated. Another slide, another study that I really liked, but it shows physical activity among US adults from the 1960s. A little bit, and sorry, I don't have my pointer, but I'll ask Ricardo to kind of do that. That hashed line there at the top is leisure time activity. And if we go from the 1960s up to 2030, over on the right side, projected to 2030, That's about a 40% reduction in leisure time activity. And then Ricardo, up at the top, there's the sedentary time, that solid black line, again, a 30 to 40% increase in sedentary time. Occupational activity is the kind of the white one there. Again, we're sitting in front of screens all the time now at work, and we can see that. Domestic activity is the gray shaded one. Again, this parallel decline in domestic activity. I'm old enough where we used to have to get up and go over to the television to change the channel. Remember, some of you remember those days. We opened our own garage doors. We had our own. Today, lots of people around where I live in Silicon Valley, they have their food delivered from one of these, high-end delivery services. They don't cook. They have a vacuum cleaner, that little robot that runs around the floor. We don't do those things now. Our domestic activities are lower. Everything's lower. We're less physically active. And go to the next one. And I show this because this is Brazil, and talking to a Brazilian audience, and there's data available just going back about 20 years. But you can see those same patterns. Look at the leisure time physical activity in the shaded bar there, how dramatically that's declined over 20 years. Same for occupational and domestic activity, and then sedentary time. It's gone up, for all of us. So. And this is, again, a really interesting paper. They looked at data available in at least a dozen different countries. So again, some recommended reading, and that is at the bottom, the citations at the bottom there. And then go ahead to the next slide, Ricardo. And again, this is something that we all know. This is the growth in worldwide prevalence of overweight and obesity. This is a study from The Lancet a couple of years ago. You can see the United States is out in front of everybody. We're the red squares there on the top. In the 1970s, 40-some% of us in the United States were either overweight or obese. And then if we take that out to the right to 2020, it's about 70% now. Followed closely by the UK and these other countries. You can see Spain, Austria, Australia, France, and so on. They're behind us, but you can see that trend upward. Obesity is growing throughout the world. And in the most, the biggest problem, as some suggest, people who do this for a living, it's developing countries now that are probably the biggest problem because of their larger populations. But you can see these other countries that there's that trend. They're just 10, 15 years behind us, but they're all headed that direction. And this has been paralleled, as you all know, by an increase in prevalence of diabetes. Go ahead to the next slide. And again, since I'm talking here, this is being hosted by Brazil. Brazil was not shown in that last slide, but you can see that this shows that obesity has grown more quickly in Brazil than the rest of the world. The little orange line there is the global average, and then Brazil over it. And this is just the last, 10, 12 years there, showing how rapidly obesity is rising in Brazil, which would be considered a developing country still, correct? So go ahead to the next slide. And here's the biggest problem of all is of course this. In 1990, we looked like this, and our TVs were much bigger, and now, of course, we look differently in 2020, and our TVs look quite different, as you can see. So go ahead to the next slide. So I want to let's make this last point here, that fitness provides risk information beyond the traditional risk factors. And the reason that we became interested in this because I would have these discussions with clinicians or talk about this issue, and the response I would get, would be, I know a patient's diabetic and they've smoked for 40 years, and they, do we really need fitness? And how do we measure that? How can we estimate it or measure it? Of course, as I mentioned before, we don't want to put everybody on a treadmill. That's not the point. But there are statistics now, new statistics that demonstrate that fitness provides risk information beyond the traditional risk factors. Go ahead, Ricardo, the next one. And there's a statistic that's called net reclassification improvement that I've been interested in. It showed up just around 2007, 2008 from a group at Harvard. And it asks this question: how frequently correct reclassification of risk occurs versus incorrect reclassification by adding a new variable to a model. And then the next one, Ricardo. In our case, in the context of what we're talking about here, it addresses the question, does fitness more accurately stratify risk when added to traditional risk factors? And then the next slide. So we did this a couple of years ago. We looked at meeting the minimal guidelines on activity. This was about, in the VETS cohort, again, that I mentioned. It's about 7,000 patients who underwent an exercise test for clinical reasons. And, one of the things that, it's been Vic Frelicher's philosophy for many, many years, the exercise test should be an extension of the history and physical. So as part of that, we asked a simple question, not a 5-page questionnaire, not taking all that time, but just a simple question as part of the history. Do you exercise 3 or more times weekly, enough to feel short of breath, feel your heart thumping, or work up a sweat? And the yes/no answer to that. Patients who said yes, we considered that generally speaking, they met the minimal guidelines on physical activity. And we have some data to back that up. So a yes answer is actually accurate. That actually does reflect that. So we followed this group for all-cause mortality for a mean of 11 years. And then on the next slide, I'll explain this. This is the net reclassification improvement. And then hit the button once there, Ricardo. So if we look at the baseline risk factors, go ahead and click, hit the button, Ricardo. Yeah, there we go. So the baseline risk factors are the usual things: age, body mass index, hypertension, hyperlipidemia, smoking, and diabetes. That's our reference group. Knowledge of those standard risk factors. So the reference is 1 for that. And then hit the button again. Now, if we add physical activity, just a simple knowledge of meeting the minimal guidelines on activity, we correctly reclassify 23% of the population in terms of their risk for mortality. Let me state that differently. 23% of the subjects would be misclassified if we didn't have knowledge of their activity level, just meeting the minimal guidelines on activity. And then if you go to the next one, Ricardo, if we add fitness to that, exercise capacity, then we've correctly net reclassified 43.5% of the population. So the answer to that argument is that physical activity and fitness have a huge impact on how we classify patients in terms of their risk for mortality or other events. And go ahead to the next slide. And from that study, we did later did a little bit longer questionnaire in this population and put them into quartiles in terms of their activity. And again, you've seen this before. The most active group is the reference group. And when we compare them, those who are sedentary to the active group, they have 4.3 times the risk of mortality. Note also, and I'll point this out again, the sedentary to minimally active group, Ricardo, there. If you get out of that sedentary group and you're just minimally active, you cut your risk for mortality by about 60%. Now, the moderately active group, the way we define it in our questionnaire, they meet the minimal guidelines on activity. So the minimally active group doesn't even meet the minimal guidelines. We've just they do enough to get out of that sedentary group. And you can see what impact that has. Getting people out of the least fit or most sedentary group has a huge impact on health outcomes. And on the next slide. And then one more example of this, we were interested in heart failure incidence because it's such a big issue and it's a very costly, in cardiology, it's our most costly condition, is heart failure. So we looked at reclassification of risk for heart failure in the VETS study again. This was 21,000 subjects who were free of heart failure starting in 1987. 1,900 of them developed heart failure over a mean follow-up of 12 years. And we did the net reclassification improvement again, relative to standard risk factors. We found that low fitness was as I mentioned before, it was the strongest predictor of risk for incidence of heart failure among all of the clinical and exercise test variables. That surprises our other cardiologists because, you know, they think of other things always. Adding fitness to standard risk factors resulted in a net reclassification improvement of 37%. I think have that on the next slide, Ricardo, and then hit the one more time. The just circling the 37%. That's the table there that shows the net reclassification improvement. Stated differently, 37% of the sample would be incorrectly classified if we did not include knowledge of their physical activity pattern or fitness. And then again, Ricardo, yeah. So, and then to the next slide. These are bar graphs, again, just the relative risks for heart failure between quintiles of fitness, showing if the least fit group is the reference group, the highest fit group has about a 76% reduction in incidence of heart failure. And again, like before, you can see the gradient. As you become more fit, your incidence of heart failure is lowered. Let me make one other point I should have made before. That least fit group over there, you know, people see slides like this and they say, well, great. They're the oldest, they're the smokers, they're the diabetics, they're on, you know, they've been hypertensive. That's not the case. We correct for that. So that you correct for all of those risk factors for age and the other risk factors. So it kind of evens the playing field. It's not perfect, but you even the playing field for various risk factors. So you sort of take out the influence of age that way. And then hit the button there again. So we also, I mentioned this before, in this study, a 19% lower incidence of heart failure per MET achieved. And I talked about other studies. In our studies, we generally see a 10 to 20% lower incidence in mortality per MET achieved. But here, in this case, every MET higher, you lower your incidence of heart failure by about 19%. So again, small increment in fitness has a major impact. So I'll summarize here then. I hope I made the point that that we're far too sedentary, and it's getting worse in not just the United States, but we used to talk about this problem. This is a problem across the Western world. That's not the case. It's South America, it's developing countries, it's Asia, it's all over the world now seeing these trends in the wrong direction. And then the next one. Cardiorespiratory fitness should be treated as any other of the traditional vital signs. So, and again, there are ways to estimate fitness now, more and more people coming out with easy ways to estimate fitness. But as a minimum, we talk to our patients about fitness and about physical activity patterns, and just like we would take their blood pressure. And then the next slide. Higher cardiorespiratory fitness is associated with better health outcomes. And we've been looking at incidence. I mentioned heart failure. We've looked at incidence of kidney disease. Andre was talking about high levels of physical activity and AFib. We now have IMPRESS, our second study on AFib incidence. Higher fitness is associated with lower future incidence of AFib. So, which runs counter to some of the other studies that Andrea was talking about. And then the next slide. Physical activity counseling. I finished most of my talks with this final statement here. I really think that physical activity counseling should occur during every clinical encounter. At least a mention of it. It should be just like we look at lipids or take blood pressure or anything like that, like any other vital sign. So I'll stop there. And again, Ricardo and everyone, thank you for the opportunity to speak about this topic, as you know, that I feel passionate about.
Perfect. 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 Thank you very much, John. It was a travel among old risk factors, but for some people, new risk factors. we know a lot about physical activity. You have shown us data from your lab and from people from all over United States. We can have this kind of data from others since 1954 with the buses in the UK, in London, and all the information goes in the same direction. It's amazing how people do not pay attention in this as they should. This fascicle from the Lancet, June 2012. There is one guy called Pedro Curi Alau. He is a very important person right now in our country. He was one of the papers, the bicycle organizers, and the image that you have shown, that at that moment, absolutely 5.3 million people in the world died. Absolutely more than tobacco is something unbelievable. Probably now is much more. I remember your paper. You have shown us the New England 2002, May 2002 paper. You and Vic and others, and probably is the most cited paper in the literature after you published it until now. I have a question. It's a very simple question. Probably the answer is not as simple. A lot of patients they come to our offices and they ask, I do not have time in the 168 hours that a week have. We can exercise, but I can exercise 1 hour per week, or I can exercise 1 time per week. What do you, if the person is a healthy person? What do you say about this?
Yeah, and no, that's a good question. And in our case, we're mostly seeing 60, 70-year-old veterans. Many of them are retired, and it seems unbelievable that they can't find 30 minutes most days of the week to do something. But what I do is, it counts. If you want to work in the garden, or you want to walk the dog, or whatever it might be, household chores, those things count as well. And we don't need one of the slides I have is Ayman Lee's recent paper on steps, where 4,000 steps a day do almost as well as 10,000. We don't have to overwhelm people, and this idea that a lot of healthcare providers and clinicians that I meet with, they think that to get the benefits of being physically active, we have to make triathletes out of everyone. That's not realistic, of course, but some walking. All of our patients have time. They say they don't, but they do. It's a matter of finding time in the day, but encouraging things that they enjoy, whatever it is. And they can, again, it can be walking the dog, or working around the house, or going to a senior center, whatever it might be. We encourage them to find that time and set the goals small. Give them these pedometers. Now it's good enough. Well, we all have smartphones. There are, you can call 30 apps on your smartphone and it'll count your steps, but give them a $5 or $10 pedometer and say, can you do 2,000 steps this week? And then follow up with them and see if they can. So those are the kinds of things that I try to do, because I know it's possible for the vast majority of the public and our patients to do something. Try to get to that 150 minutes a week.
So I don't need to remember everybody who was watching our symposium that exercise is physical activity, but not all physical activity is exercise. So we should move. And in this line, Professor Sandra Fuchs, our host, she is asking, what about the risk of those who fulfill the criteria for minimum of physical activity per week, but at the same time spend much time sitting during working time?
Yeah, Yeah, I think, we all worry about that too. I worry about that. Ricardo, as you know, I'm very physically active. I'm a daily exerciser, but God knows how much time we're all spending in front of our computers during the day. It's changed from 10, 20, 30 years ago. I worry about that as well. And there are data on different sides of this. And again, I have some of the slides. We've looked at this in the VA as well. Didn't have time to show all of that, but there are data to show that even if you're relatively physically active but spend an inordinate amount of time sitting, you're at risk. Other studies, there's some good data to show that you if you're highly physically active, you overcome all that sedentary time that we're spending. I kind of like to, I like those slides a little bit better because I'm in that group, and I think a lot of you are too. And Ricardo, I know how physically active you are. You're a daily exerciser, but all of us are spending a lot of time sitting. And where we live around here, we're spending a lot of time in our cars getting to and from work. And the first thing you do is that first hour is just sitting, answering email, and then you're just sitting so much more. It's a problem, but it's a really good question. I think we need more data to clarify that. There are data on both sides of that issue.
Yes, there is a beautiful figure was published in JACC last year. They have shown how in one quintile in quintiles the physical activity level, and in quartiles how many hours the person stay seated, and below 150 minutes per week, it's exponential, the curve of cardiovascular mortality.
Yeah.
So
yeah.
I remember one paper, one figure from Claude Bouchat, that he wrote, sitting too much will kill you. And there were two guys, young guys, playing at that time Atari. And for me, that was fantastic. Just the last question, because we should go with Aaron. Miguel Cardenas asked, in developing countries, we struggle to perform massive cardiorespiratory fitness tests, mainly for cost barriers and lack of health insurance. Could you suggest a low-cost minimum test batteries?
Yeah. So, and we've worked on this. There's even this, particularly since the 2016 AHA statement, there's probably 8 or 10 good papers on estimates of fitness, non-exercise test estimates of fitness. There's even a review article on that. Be happy to send that to you so you could pass that around. The one that I think is most widely used is Ulrik Wislof's study from Norway. They have a really nice paper where they looked at outcomes and non-exercise test estimates of fitness. I would recommend that one, but there's been a bunch of them the last few years where you could just, again, it's part of a history and physical, just take a minute and talk. It takes age and gender and various factors, weight, in models where they estimate fitness reasonably well. Ricardo, you know our VSAC, Veteran Specific Activity Questionnaire. We have about a 0.80 correlation with their exercise capacity. And that takes about 2 minutes, for a patient to look over the form. So there's a lot of those tools around to do that.
If I can summarize in one sentence your lecture, I would say physical inactivity kills. Let's move.
Okay, good. Perfect. That's perfect.
John, thank you very much for your time. And the last thing that I would like to say is hire me to work with your slides. But can I live in Mountain View again?
Oh, absolutely. You're welcome. Yes, yeah. That would be welcome. And I'll hire you for all of my talks. Good job on the slides.
Thank you very much. A big hug. And again, I would like to say that before talking with, introducing Aaron Bagish, Dr. Aaron Bagish, I would like to say that we are taking care, and there is physical distancing here with my colleagues, and I am not wearing masks, but they are wearing masks, and we are online with the COVID recommendations of physical distancing and not agglomeration and so on. Thanks, John. Bye. See you later.
Okay, good. Thank you.
Okay. Bye-bye. Okay. Hi. In the big rectangle where our faces are.
Okay.
And now open the slides, please.
Perfect.
Perfect.
So you can see my slides now?
Yes, everything. So
Although we need to ask for permission to record.
yes, again, I forgot. Sorry, Aaron. Is it possible to record this lecture, because a lot of people are not able to see in real time? So we are asking the lecturers to give us the permission or not.
Sure, no problem.
Thank you very much. Thank you, Dr. Aaron, to be with us. It's a very important event, and it's very important to have you here. I know you from a long time, and how much you are doing for science in Harvard, Massachusetts General Hospital, Heart Center, and so on. Dr. Aaron Bagish is an associate professor of medicine at Massachusetts General Hospital, director of the cardiovascular performance program at the Massachusetts General Hospital Heart Center. And his lecture will deal, and the title is Cardiac Risk from Long-Term Sports. Now we'll have the honor to have you with us. Please, Aaron, be my guest.
Thank you, Ricardo. Let me just take a moment to thank you and your colleagues there for organizing this and for including me. It's been a great program so far, and I look forward to the rest of it. And I'm more than delighted to be able to contribute a small piece. And this talk flows nicely from Dr. Meyer's lecture, in which the message to all of us that we need to move our bodies is quite clear. And what we'll be discussing over the next half hour or so is really what happens when you push your body quite hard, particularly as you age. And this is the clinical space that I, and I think many on the call, live in. And what we really want to do is understand the interface between high levels of exercise and aging, particularly with respect to cardiovascular disease. So, title of this lecture is Cardiac Risks from Long-Term Sports. By way of transparency, here are disclosures, groups I have financial relationships with, just so you understand my background. I don't think too much of this plays into the talk from a bias perspective, but I want everyone to be clear where I come from. And so let me begin by introducing you to Ted. Ted is a patient of mine who has won virtually every international rowing competition that one could ever enter above the age of 65, 70, and he continues to win medals on an annual basis. And what's interesting about Ted is he does so living with coronary disease, atrial arrhythmias, and a dilated aorta. And so our work in folks like Ted is to try to understand how to allow them to maintain their athletic identity and at the same time, if they're unfortunate enough to have to deal with it, manage their cardiovascular disease. So I use Ted as an example to begin by defining the master's athlete. And the definition that we favor for this are men and women above the age of 35 who exercise vigorously at least 5 hours a week. And again, going back to John's talk, that's 2 times physical activity recommendations. And to really be a master's athlete, this exercise has to really focus on goals, whether they're goals, personal goals or competition goals. There's a purpose to doing this exercise. So I'm not sure if any of you remember where you were on November 27th, 2012 in the evening. I don't remember that night, but I remember the next morning when I got to work and had 465 emails in my in-basket, and they were all about this editorial, which was published in a very popular American newspaper called the Wall Street Journal. And the editorial was entitled, "One Running Shoe in the Grave." And the editorialist in this paper writes that running can take a toll on the heart that essentially eliminates the benefits of exercise. Running too far, too fast, and for too many years may speed one's progress toward the finish line of life. Now, this editorialist, who was not a physician, didn't make this up. He was attempting to summarize a medical editorial, which was soon to be published in the British journal Heart. And here is the infamous editorial. I think many of you are familiar with it and have probably read it. It's entitled, "Run for Your Life at a Comfortable Speed and Not Too Far," written by Jim O'Keefe and Carl Abbey, two American cardiologists, both whom I know well and have a lot of respect for. And what they did in this editorial is use 4 lines of evidence. They looked at some old epidemiologic data through a new lens. They presented some case studies of fit athletes dying during sport. They looked at some new observational data that suggests that maybe athletes might develop some form of pathology. And they looked at some new epi studies coming out. And they basically made the claim that beyond a certain level of exercise, not only do you no longer get return on your investment, but you may actually do some harm. Now, it turns out, to be fair, this was a commissioned article, internally peer reviewed. None of us in the field that actually think critically about this ever had a chance to look at it before it came out. And if you go and look carefully at the lines of evidence in this article, none of them really stand up to rigorous scientific scrutiny. But one of the things I've learned over the years doing this is where there's a lot of smoke, there's usually a little bit of fire. And so I think it's important for those of us that work with athletic patients to ask the question, does too much exercise over too much time hurt your heart? And I would say, importantly, affect morbidity and mortality. And if so, what does this pathology really look like? So why talk about this topic now? Well, there are 3 good reasons. One is there are emerging epidemiologic data sets that are for the first time really focusing on people on the very high ends of fitness. And they are suggesting that there is a diminishing return as you do more and more exercise above a certain level. There are many anecdotal observations of physically fit athletes dying during exercise, and perhaps, just maybe, this is because of some sports-induced cardiovascular disease. And then there are a growing number of observational data sets, some of which I'll describe today, which are really looking at the burden of pathology among athletes and athletic patients. And perhaps, and again, I'll leave you to make your own conclusions as we talk through this topic, perhaps there's a syndrome of cardiovascular abnormalities that's caused by chronic exposure to both high volumes and high intensity exercise. So to begin this discussion, I want to take you back to some basic fundamental concepts around dose response. As most of you are well aware, when we give an organism any sort of stimulus, we can define their response by both an efficacy and a toxicity curve. And when we give a patient a medication or indeed prescribe exercise, we hope they're going to live in the margin of safety where they derive benefit or efficacy and they avoid toxicity. But indeed, when you look at dose response curves across populations, you realize that individuals in the population do not all adhere to these curves. You have benefit outliers, so people that derive a lot of benefit despite sub-efficacious doses, or people that get no benefit despite toxic doses. And you have toxicity outliers, people that develop toxicity with very low exposure and people that develop no toxicity despite tremendous amounts of exposure. Now, when it comes to exercise, and the question that we're all asked very frequently is how much exercise should I do? There's no one right answer to that. And what I'd like to impress upon you is that the amount of exercise that's appropriate is almost certainly a function of what outcome you're looking for. So let's start with the simplest linear curve. This is the curve that applies to most young, healthy, competitive athletes. The more you train, the harder you train up to some very, very high level, the better you'll perform. So this is the race performance curve. What about curve B, the asymptotic curve? Well, this is actually a good curve to define the relationship between exercise and traditional cardiovascular risk factors. Some of the things that Jonathan talked about in the prior talk, hypertension, dyslipidemia, glucose handling. If you get off the couch and do something and progress through 1, 2, 3 times physical activity, you'll continue to improve those risk factors, but at a certain point, you get no further benefit. And this is really the concept of diminishing returns. What about this bimodal curve in the bottom right of your screen? This is actually a fascinating story, and this is the relationship between exercise and indeed weight loss. And that is that if you go from doing nothing to something, you will stimulate some weight loss, but to really sustain meaningful weight loss, you actually have to do a fair bit of exercise, at least 2, if not 3 times physical activity recommendations, and that has to be coupled with a calorie-restricted diet. And of course, my favorite that I spend a lot of my time in clinic talking to my patients about is the bell-shaped curve, and this is the relationship between how much you exercise and your marital success. If you're simply out running and riding too much, your spouse is not going to stick around too long to wait for you to come home. So what do we know about exercise and longevity? Well, there's some unanswered questions, but there are some things that are quite clear, and that is that young elite level athletes, particularly those that participate in endurance sports and to some degree team sports, will live longer than sedentary or even normally active reference. These are data that come out of Northern Europe, and they're quite instructive. And what you can see here numerically is that endurance sport athletes, so in this study, cross-country skiers and long-distance runners, lived on average 5 to 6 years longer than sedentary reference. Team sport athletes, so hockey players, football or soccer players, basketball, other track and field sports, enjoyed a smaller but still significant amount of longevity benefit. But in contrast, power sport athletes, people that did a lot of isometric physiology, didn't enjoy any appreciable longevity. It's not just about how long you live, it's about your interaction with the healthcare system. And again, data coming out of Finland make an important point, and that is that people who are young and physically fit and push their bodies hard, once they start to age, they tend to enjoy relative freedom from a number of different types of diseases, including those that we care about as cardiologists, so diseases of the circulatory system. Probably most importantly, ischemic heart disease, but this holds true across cancer, diseases of the respiratory system, diseases of the digestive system. The only outlier here is musculoskeletal disease, which should come as no surprise because indeed one of the clear associations between pathology and exercise is joint health. We won't talk about that more today, but that is incontrovertible. So exercise is so good, and lots of exercise is so good, that an infamous paper by California pathologist Thomas Bassler put forward the concept of exercise immunity. And that is that if an individual could run 42 kilometers, so the typical distance of a marathon, that they were thought to be completely immune from atherosclerotic coronary disease. And indeed, this theory came to be known as the Bassler hypothesis, and it was one that attracted a lot of attention. It would be nice if that was the case, particularly for those of us that run marathons. Wouldn't it be nice to never have to worry about coronary disease? But we now know that that's not the case. So just very briefly, data from the RACER study, which was a US-based study that I led here probably about a decade ago, in which we looked at cardiac arrest during marathon running, made a very important point, and that is that rarely but importantly, healthy, fit runners can die and do die during exercise. And when it happens in the context of a marathon, particularly above those who are 35 years or older, the dominant pathology is coronary artery disease. There's no question about that. So what we're going to really think about over the next 20 minutes or so is, why do these athletes get sick if they're doing everything right? First, a little digression, and that is, who are the masters athletes we're talking about? Well, I can't comment about who they are in your community. I can tell you about who they are in our community, but I suspect there are some similarities. So these are some data from a study we did a number of years back, in which we recruited a large group of masters athletes in the greater Boston area who were members of rowing clubs, triathlon clubs, running clubs, and we put them through a very non-biased health and wellness questionnaire to try to understand their perceptions of their health and their interactions with the medical community. And we learned a tremendous amount from this. The first we learned is that these individuals go to the doctor and they get lots of testing done. So whether it's ECGs, exercise stress tests, echocardiograms, increasingly cardiac CT scans, their doctors were testing them. And these doctors were not crazy. They were doing so because they identified that these individuals harbored a significant amount of cardiovascular risk factors. So whether it's a family history of premature atherosclerosis, prior tobacco use, hypertension, dyslipidemia, obesity, these again were the healthiest looking people in our population, but they had risk factors. In fact, only a quarter of them were risk factor free, and a whopping 10% of them already had established cardiovascular disease, which was accounted for almost exclusively by atrial fibrillation and coronary disease. The other really important thing we learned is that 40% of this group felt dissatisfied with their health care because when they went to their doctors simply either dismissed them or mistreated them because they didn't understand the role of athleticism and sport in their life. So what I want to do with you is ask 4 very important questions. And these are the 4 questions that we get asked in clinic on a daily basis. And these are the questions I think as a sports cardiologist, you want to be positioned to be able to answer, at least understand what we know and what we don't know. So the first question is, do endurance sports cause arrhythmia? I know you've heard a little bit from my good friend Andre Lagersh about this earlier, so I'll try to be brief, but it's an important topic. So no diagnostic dilemma here. This is a 52-year-old marathon runner who presents with decreased exercise tolerance. His 12-lead electrocardiogram definitively shows atrial fibrillation. And we now know through a series of very nicely done observational case control studies that masters athletes are at increased risk for atrial arrhythmias, particularly atrial fibrillation, than their sedentary age-matched controls. There's no debate about this anymore. This is the clearest example of causal pathology related to exercise that we have. Probably the most famous of these, which I think many of you are familiar with, is a study that came out of Sweden, looking at participants in the Vasaloppet, which is a 90-kilometer Nordic ski race that's held there every year. And what Casper Anderson and his group were able to do is study more than 50,000 participants in this race over a 10-year period with reasonable follow-up. And the question they ask is, does the incidence of arrhythmias correlate with the race time, so how fast these men were, which is a surrogate for how good they were, or the number of races that they skied, which is a surrogate for how committed they were and how much volume they got. And indeed, both of these surrogates were predictive of arrhythmia, and atrial fibrillation was the dominant rhythm. So why does this happen? Well, the classic and oversimplistic explanation is that the atrium, like the ventricles, responds to endurance training over time and dilates. And indeed, left atrial dilation is one of the hallmarks of the endurance heart. But to blame atrial fibrillation on atrial dilation alone would be inaccurate. There's a long list of things that make masters athletes more at risk for atrial fibrillation. Certainly dilation, but I would submit probably more fibrosis. There are important changes in the autonomic nervous system, including persistent vagal tone at rest, coupled with sympathetic surges during exercise, with left atrial hypertension and some element of chronic inflammation. There are genetics. There are lifestyle factors, including alcohol consumption, caffeine, and psychosocial stress. And indeed, if you think about this complicated picture, what we can say is that the strongest association between endurance sport and any causal pathology lies with AFib. The data are clear that as our aging patients who engage in high levels of sport continue to age, that they are at increased risk for AF. I'm still not 100% certain in my own mind how much of this is truly the sport or the lifestyle choices that come with it, but we know it's a big issue. The problem, as I'll try to impress upon you, is that the treatment strategies that we have right now are completely based on extrapolations from sedentary populations or expert experience. And this is where I think over the next 10 years, we as a field have an opportunity to really add and to present some primary outcome data from the right source population. So wait a second, you guys are cardiologists and you're sitting there thinking to yourself, what is he talking about? We've got this atrial fibrillation thing figured out. We learned from the AFFIRM trial that you could manage atrial fibrillation with either rhythm control or rate control, and you just take your pick, it doesn't matter. We have great scores for predicting bleeding risk and for predicting stroke risk. And indeed, we now know that atrial fibrillation can be treated with catheter ablation, so why not just ablate everyone? Well, these lessons work well, but when you start applying them in a masters athlete population, you realize there are limitations, and I'll give you some examples. Rate control versus rhythm control. You do this enough, you'll find people like this coming to your office telling you that rate control ruined their life. How about having the discussion about bleeding versus stroke risk with a masters athlete who asked the question, were these scores really made for people like me? And what about this question of sinus maintenance, which ends up being the way we treat most of our atrial fibrillation patients? Why not just ablate everyone? Well, it turns out that if you follow enough patients who have had atrial fibrillation ablations, particularly successful ablations with a lot of substrate modification, you routinely hear, "I'm cured but not fixed. What's going on, doc?" And the answer is that aggressive substrate modification, which can and will cure atrial fibrillation, oftentimes leaves the atrium physiologically impaired and unable to perform its duty, which is really to augment cardiac output. So while atrial fibrillation ablation is an important part of this care paradigm, it shouldn't be regarded as the only option or the option you jump to first. So very briefly, the algorithm that we use in our program to address masters athletes presenting with a new diagnosis of PAF. The first thing is simply to define and treat the underlying risk factors which may be contributing. And these include disease processes like hypertension, obstructive sleep apnea, but also importantly, lifestyle factors, including alcohol consumption, caffeine consumption, and stress. We do indeed spend a fair bit of time assessing stroke risk and bleeding risk, and we follow guidelines in which we try to anticoagulate people that have a CHA2DS2-VASc score of 2 or greater. But indeed, this is always a discussion in an individualized shared decision-making fashion. Everyone who comes through our program gets a maximal effort exercise test, not necessarily because we think AFib is caused by coronary disease, but as you are all well aware, class 1C antiarrhythmics, which are an important treatment modality in this population, are contraindicated in coronary disease, so we use this to help us refine what our treatment options are. And importantly, once we've gone through the initial evaluation, we talk to our patients about how big a deal is this disease in your life? How often does it happen? When it happens, how sick do you feel? And in people that have very infrequent episodes, less than twice a year, and they're short and self-limited, we often do nothing and help them just over time deal with this and realize it's not the end of the world. However, most people over time will go on to have recurrent episodes with more symptoms. And so there we start by asking whether or not the disease is triggered by sympathetic activity or by vagal tone. And we treat those two conditions very differently. So let's move on to the heart muscle. Does endurance sports cause cardiomyopathy? So very long ago when we were just getting started with the Harvard Athlete Initiative, which is now an ongoing program in which we study sports physiology, we used strain echocardiography, which was a brand new technique at that time, to look at what happened to systolic function before and after a 90-day period of training escalation in a group of rowers who were embarking on a very ambitious training protocol. And so looking at this group of men, we were able to draw strain maps, which look at deformation in the 3 principal vectors, longitudinal, radial, and circumferential. And everything here that you see represents changes in strain after 90 days of training, with things in gray or black representing a gain of function, and things in red representing a decline in function. And what we saw is that in the circumferential vector within the septum, that there was actually a relative signal of systolic dysfunction. And this was really quite interesting. It was not something we expected, but where it really started to become clear what was going on is when we realized that the most circumferential fatigue was occurring in those that had the most RV dilation. So the people whose right hearts got bigger were the ones who appeared to have some element of fatigue or dysfunction in their septum. I will say when we published this paper, we had just a few sentences in the discussion pointing out the fact that we observed this, but really didn't have any sense of whether or not this was accurate or of any clinical relevance. But what we did find is that some studies came out after the fact that were really helpful in terms of contextualizing this. So the first from Greg White and his group in the UK, a small case series using cardiac MRI to look at myocardial structure in masters athletes with some small numbers, but an important observation that these athletes had what looked to be non-ischemic scar, and a fair bit of this non-ischemic scar was focalized in the septum, particularly at the RV insertion points. And then, of course, Andre Lagersh and Heidebuchel's study, which I'll talk about in a little more detail, which made the point that perhaps the interventricular septum and the RV insertion hinge points really are the Achilles heel of the athlete's heart. So what did Andre do? He embarked on an ambitious study. He recruited 40 well-trained athletes. These were competitive athletes who were finishing high in race scores. They were free of symptoms. They were free of risk factors. They had no inducible ischemia on pre-study stress echo. And he went on to study them with MR, echo, and some biochemistry at 3 time points. So at baseline, before a race, immediately at the conclusion of a race, and then a week or 2 after their completion. And just looking carefully at the people that he studied, they were marathon runners, triathletes, cyclists, and I'll call your attention to the third line from the bottom. These were indeed legitimate endurance athletes with peak VO2 ranging from 140 to 160% predicted. So what happened to these people? Well, it turns out, as it should come as no surprise, when they raced, there were physiologic changes post-race. Their heart rates were up, their systolic blood pressures in both the systemic and the circulatory system and the pulmonary circulatory system were down. And when he examined right ventricular function using a number of different echocardiographic modalities, all of the indices were pointed in the same direction, and that was that there was an RV fatigue signal. And indeed, the schematic that's pulled from this paper that explained this is that as the RV is exposed to high volumes of cardiac output over many hours, the RV becomes fatigued, it dilates, it preferentially pushes the interventricular septum to the left at the expense of the LV internal dimension. And when Andre went on to look at the MR scans in these individuals, what he found is that 5 out of 40 of them indeed had patchy fibrosis within the interventricular septum. And this was indeed a wake-up call for all of us, because I think many of us for many years have thought about the athlete's heart as being a completely benign adaptive phenotype with no chance of it being a pathologic signal. But this paper really did challenge that notion for the first time. So how might this happen? Well, I think it takes not just one factor, but probably a pathogenic cascade. So certainly chronic extreme volume and intensity, so lots of exercise, but lots of exercise coupled with inadequate training and recovery. So too much exercise without enough rest. There's almost certainly something at the level of the genetics, host susceptibility. It's not ARVC genes, that's been teased out. But I would submit more importantly that there's usually going to be some secondary process, some garden variety cardiovascular disease like uncontrolled, unrecognized hypertension, prior infection, which is a relevant topic in the COVID-19 days. And of course, something we worry about increasingly in our master's athlete is the use of performance-enhancing drugs. And so if all these things align, it's probably possible to end up with a heart like this. But I do want to remind everyone that, these data are really preliminary. I think while it's possible that a patchy fibrotic picture can and does exist in some master's athletes, in our experience scanning hundreds of these people, we see it relatively infrequently and almost never see any clinical correlates with it. So at this point, I would say these data are preliminary and really not of any clear clinical relevance. So let's switch to the aorta. I think this is the newest part of this story. And up until recently, I think the aortic story has been a simple one and one that we haven't paid too much attention to based on studies like this. This is a study that comes out of Italy, Antonio Pelliccia and his group, in which they took a large number of young athletes who were healthy that participated in their screening programs. So these are young people in their early 20s. And when their aortic sizes were looked at, the message was pretty clear that you see really very few of these people that exceed the upper limits of what we would consider normal. So in this case, when we look at men and we apply a cut point of 39 millimeters, or women, when we apply a cut point of 33 millimeters, that really very small percentages of them exceeded those, and those that did probably had some element of pathology that explained it. What was interesting is that the biggest explanatory factor around aortic size in this population was simply height, reminding us that the aorta and the actual height of the athlete are very important in terms of asking what's normal and not. But the picture is a little bit more complicated. And I think we know that now from Paul Thompson's nice meta-analysis, which followed the study I just showed you, in which he pooled 23 different studies which allowed him to bring together data on huge numbers of athletes. And what Paul and his colleague found is that indeed, when the athletes were compared to non-athletic controls, that on average they had a 3.2 millimeter larger diameter within the sinuses of Valsalva and a 1.6 millimeter larger diameter within the aortic valve annulus. And the predictors of these were, again, being an athlete simply gave you the risk of having a bigger aorta, that men were more likely to have this than women, and that this was almost exclusively driven by endurance athletes. So male endurance athletes tend to have bigger aortas than other people. This led us to do a study which I think is most relevant to this talk, and one in which we really focused on masters athletes. So we recruited a number of competitive runners from the Boston Marathon, as well as individuals that were participating in international rowing regattas in Boston. And we simply asked the question, does exercise history and does being a competitive masters athlete play out with respect to what the aortas look like? And these were men and women in their 50s and 60s. They were, not all perfectly healthy. They had some smattering of cardiovascular disease, but most of them were relatively healthy, and they had exercised for a long time. So 26, 24, 20, 22 years of exercise, and all of this was competitive. So interestingly, what we found, and in stark contrast to the younger data sets, is that a significant minority, 25% of men at the sinuses of Valsalva, 18% of men at the ascending aorta, had diameters that exceeded these cut points, which we would consider clinically normal. And the same was true with women. And so it really raised the question, what makes the older athlete different from the younger athlete? And is this just a cumulative exercise dose phenomenon? And what we found is that the two different places in the aorta we studied told very different stories. And that is that within the sinuses of Valsalva, certainly body size and gender mattered, but here the type of sport you did and how good you were at the sport predicted how big your aorta was. Where in contrast, when you move into the ascending aorta, it really becomes a function of superimposed hypertension. So stay tuned on this. All of these athletes are in a longitudinal surveillance program, and what we really actually need to know is whether or not these men and women with big aortas go on to develop further dilation and ultimately outcomes we care about, like aortic root replacements or dissection. We're simply not seeing that at this point. So although the follow-up study is not yet done, we're leaning toward thinking that a lot of this is a benign, potentially adaptive response, and that we really shouldn't consider myelodilation a pathology in this group. So finally, and this is my favorite one, and this is the question we get asked over and over when the 60-year-old man comes into the cath lab with his first ST elevation MI, and it occurs when he's out on a long bike ride, and that is, do endurance sports cause atherosclerosis of the coronary arteries? So I don't need to impress upon this group that exercise training moves cardiovascular risk factors in the right direction, whether we're talking about hypertension, abdominal adiposity, plasma lipoproteins. Exercise improves cardiovascular risk factors. There is no debate about that. That story is as clear as day. And what's even more interesting than that is when we understand or try to understand how exercise improves longevity, meaning why exercise makes people live longer, these risk factors only explain about 50 or 60% of that. And so there's truly something magical, probably something at a very molecular biochemical level that we still don't understand about exercise, which confers mortality benefits. So to dovetail what Jonathan said in the prior talk, we should be telling all of our patients to exercise. We should be talking about this at every clinical encounter. This is simply the most powerful therapeutic tool we have as cardiologists. So where does a study like this fit in then? Running the risk of coronary events. So this study, I think some of you are familiar with. It's about a decade old, published in the European Heart Journal, emerging from Germany, in which the investigators recruited a group of marathon runners above the age of 50 who had to have run at least 5 marathons to get into the study. And they scanned them with CT scans to measure coronary artery calcium. And they compared them to two groups, an age-matched control group and a control group that was not only matched for age, but for traditional Framingham risk factors. And what they found, quite simply, is that the athletes had more coronary calcium. And not only that, but in a few of these athletes that had high CAC scores, they went on to develop events that we as cardiologists would certainly care about. Second study, this one published in a small medical journal here in the US called Missouri Medicine, was a similar type study in which middle-aged runners, this time 59 years on average, who to make it into this study had to run 25 consecutive Twin Cities marathons, a popular marathon in Minnesota. So again, these were experienced runners. But importantly, with this study, there's a lot we don't know. We have no idea how much these men trained. We have no idea really how well they did in the race, meaning we don't know how good they were as athletes, and we know nothing about their basic physiology. But what we do know is that when they were compared to sedentary controls, this time not just with coronary artery calcium scoring, but with traditional coronary CTA, we find that these athletes had more plaque than their sedentary counterparts. So when you see studies like this, there are a couple of interpretation options. The first, which I think is the option that the authors of these studies were inclined to push forward, is that high levels of exercise just causes coronary disease. The more you exercise, the more likely you have CAD. The second is that maybe it's not the exercise, but that simply risk factors that these athletes have and bring to the exercise world are causal and that they're underappreciated because they just look so healthy. And the third, which I think is maybe the most interesting and the most provocative, is that maybe coronary disease, particularly as measured by coronary calcium, is a different beast in athletes, and it's driven by unknown, unmeasured risk factors. So let's go back to the German study and try to ask this question: do we think running caused these men to have cardiovascular problems? So there were 4 people in this study that were presented, and indeed these were legitimate athletes: 14, 22, 65, 140 marathons, and they had events that we as cardiologists would care about: ventricular tachycardia during exercise requiring PCI, stent CABG, stent, another VT CABG case. But when we ask the question, what caused these outcomes, I want us to be very careful not to just assume that because these guys did lots of running, that was the problem. And why do I say that? Well, let's look at their risk profiles. Runner 1 had a total cholesterol of 344 and was a former smoker. Runner 2 was a medicated hypertensive. Runner 3 and 4 were unmedicated hypertensive former smokers. So do we really think that it was running that caused these men's coronary disease? I would submit probably not. What about the Missouri study? Well, I'm not sure how these investigators did this, but they recruited a group of men who had run 25 marathons in 25 years, of which more than half of them were either active or prior smokers. Now, certainly smoking and tobacco use is a problem in the general population and to some degree in the masters athlete world, but I still scratch my head about how they were able to do this. But what's more important in this study than what they told us is what they don't tell us, and that is there are missing risk issues which play into the assessment of masters athletes, which are never captured well in these studies. The first is diet. And one of the things to remember is that fit, healthy people that burn a lot of calories think they can put anything they want into the furnace because the furnace is hot and it will burn. But it turns out that macronutrient choices, even if you can maintain lean body mass, are an important driver of vascular health. So athletes eat terrible diets oftentimes. We forget about this when we take our history. There's also the issue of the carefree 20s and 30s. And what I mean by this are men and women who made poor choices during the first few decades in their lives. They didn't exercise, they smoked cigarettes, they worked too hard, they drank too much alcohol, and they wake up at one point and say they want to turn their life around. And while that's an important step that we should support, again, when you're taking your history, when you meet this patient with new onset coronary disease at age 55 or 60, if you forget what happened to them earlier in life, you're going to be forgetting important causal mechanisms. And then finally, without family genetics, we really don't know much about what the true underlying genetic risk, how much that accounts for why these men have coronary artery disease. So to bring this analogy home for you, I want to take you to the Mount Washington road race. This is a very popular race that we have in northern New England here, just outside of Boston, where athletes are asked to run approximately 4,000 vertical feet over 7.5 miles. And I bring my sports cardiology fellows with me to this race every year, not because I want them to run it, but because I want them to keep their ears open and listen to conversations. And invariably, the conversations they hear help them understand why these individuals come to us 5 years later with new onset coronary disease. So very first time I did this, I took a young woman up with me who was training in our sports cardiology program. She came from a team sport background and really didn't know much about endurance athletes. And so I told her, when we get out of the car, just listen. And indeed, we lined up for the portable toilet here, and there was a conversation that occurred in front of us in which 4 men were talking about their preparation for the race. And if I could have recorded this conversation, I would have, but I couldn't. So let me remind you kind of from memory what we heard. So the first guy says, "Man, not so sure that second plate of chili nachos and the extra couple of beers last night were such a good idea. Oh well, they always say don't change your routine prior to races." So this is clearly just an example of an athlete that is able to maintain a lean body habitus because they exercise, but eats terribly. And this is certainly something to consider when we meet them and they have coronary disease. The second one, "Just wish my old man could see me now. He died at age 45 from a massive heart attack. Glad I got my wake-up call. Bad stuff runs in my family." So this is an athlete that's recognizing familial risk and doing something important to try to attenuate that, and we should absolutely support that. But if this athlete gets coronary disease, before we tell them it's because he ran too much, let's remember to take a detailed family history. Third one, well, regardless of what happens, I got to be better off than I was 20 years ago when I was smoking a pack a day and got short of breath just driving up this damn hill. Again, this is a reminder of the fact that many people who exercise aggressively later in life are doing so to try to outrun bad decisions they made earlier. And while we want to support this, when we're talking about causality between disease and exercise, we must not forget to take a history about who they were and how they lived before they came to us decades in the past. And then finally, the best one, I think, and the one that's very relevant in the era of COVID-19 is this one: cough, 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 sputter. If this race wasn't only once a year, I'd be home in bed. I feel like shit. Oh well, this little climb will help me clear out the junk. So this is an athlete that's suffering from a viral infection and is making the decision to try to run 7.5 miles as fast as he can up a 4,000 vertical foot hill. This is a bad idea. And it's a bad idea because when we have a viral infection, even if we only feel it in our nose and in our throat, our oropharynx, the remainder of the vascular tree is inflamed. So if there's ever a time when an unstable plaque is likely to rupture, it's in the midst of a viral infection. And indeed, we spend a lot of time with our patients talking to them about how to manage their health when they get sick and the importance of backing off. So is running really the main causal issue when athletes present with clinically relevant obstructive coronary disease? I don't think so. I think the issue is the risk factors they bring to the equation, and we as doctors oftentimes fail to appreciate that. It is important to just remind you that the story is not quite that simple, though, that the coronary artery calcium story is one that is evolving and one that looks very differently than it does in the general sedentary population. So 2 studies published in tandem several years ago in Circulation both reached the same conclusion, and that is that masters athletes tend to have more calcium in their coronary arteries, and that perhaps this is a dose-dependent phenomenon. And this is an important thing because if you scan enough masters athletes, you're going to find CAC. I'm not sure there's really a role for scanning these individuals, but if you look for it, you're going to find it. And why might that be the case, and what should you do about it? Well, we don't have all the answers to this yet, but as Ben Levine and I tried to lay out in the editorial that accompanied this, there are some things to think about. The first is that coronary calcium in sedentary people is probably not the same thing as coronary calcium in athletic people, and that the mechanistic evolution is probably different. While sedentary people have CAC because of traditional lipid-rich athero and a response to that, CAC in athletes is almost certainly more of a mechanical phenomenon, and it may actually be a benign scaffolding adaptation, although we need more data to prove that. The second is that we have to reconcile the fact that the fitter you are, the longer you live, but also the more CAC you tend to have. So if we know that fitness predicts longevity, how can we reconcile the fact that CAC is supposed to produce negative longevity signals? So I think what we're learning is that fitness is an important way to offset coronary injury, and it's probably CAC is less relevant in this population than it might be in sedentary people. And finally, we have a lot left to know about what to do therapeutically with these people. So the knee-jerk reaction to start every masters athlete on a statin because of detectable CAC is understandable. But until we have good data to do so, I think we need to stop and have a discussion with our patients about how they would prefer we proceed. And again, I have thoughts about this, but this is still a data-free area, but one that is clearly not as simple as it is in the general population. So to tie this all together, I want to bring you back to the dose response curve, and I want to plot masters athletes on this curve. So again, when we think about efficacy and toxicity of exercise, I want to impress upon you that the vast majority of masters athletes are going to live here in the sweet spot. They're going to get all the benefit and none of the toxicity, and they're going to live better and longer from the sports they do. Coronary disease lives in this margin of safety, and my synthesis of the data is that true obstructive coronary disease that causes angina, ST elevation, myocardial infarction, heart failure, this is not because of exercise. This is a function of the traditional risk factors and probably some unmeasured risk factors that athletes bring to the equation. Aortopathy, as we're learning, probably is a dose-dependent phenomenon with very high levels of exercise over many decades causing dilation of the aorta. But at least from our preliminary data, it's not looking like this comes with the same prognostic implications as a dilated aorta would in the sedentary population. But again, this is an ongoing story, so stay tuned. Atrial fibrillation, again, as you've learned this morning, is the best example of causal pathology we have. The more our masters athletes exercise, the more at risk they are for AFib. And our real challenge as a medical community is to develop good outcomes data in this source population, which is where I think the real need is. And then finally, this issue of toxic exposure and causing cardiomyopathy. There are some preliminary data that it may exist as a phenotype, but it's one that really doesn't have a clear clinical picture right now. And so I think this is an area that is in need of more work and a stay tuned story. So finally, just a quick word about COVID-19. I'll give you a sneak peek at a paper that will be published in JAMA Cardiology in this coming Monday. And this is an update from a group of us here in the States, really trying to ask the question, how do we deal with coronavirus and athletes? And there have been several algorithms that have been published, some from the from Europe, some from the US, and many from other countries. But to date, there's not really been a comprehensive one that's looked at how to think this through in masters athletes. And so this algorithm, which I won't belabor because you'll be able to read it in detail in 2 days, makes the point that in masters athletes who have very mild or asymptomatic COVID infection, that they probably only need the recommended 10 days of rest and recovery and quarantine, and after that return to play with slow and gradual resumption activity is probably all they need. It's really the people that had significant disease, so were sick enough to be home in bed, particularly those with cardiovascular symptoms, so chest pain, inappropriate shortness of breath, palpitations. These are the ones that we as doctors really need to engage with and think about on an individualized level what type of testing needs to be done. And certainly if anyone was sick enough to be hospitalized, these are people that as cardiologists, we need to hold out of exercise until we get testing to confirm that their heart health is reasonable. So much more to come on the COVID-19 and masters athletes story. We are accruing data. I'm sure other people on the call are doing the same. But the important thing is we need to not treat all forms of COVID equally, because mild COVID and severe COVID are very different with respect to heart implications. So with that, I'll leave you with the finish line of the Boston Marathon, and thank you very much for your attention.
Aaron, fantastic. Thank you very much for being with us and giving us this beautiful presentation. For sure, people start to think about something. Maybe I can give you a hint. Next time you can make a lecture. Instead saying cardiac risk from long-term sports, you can say cardiac benefit from long-term sports, because we talk a lot about benefits as well. And this is the message. Not in all circumstances, if you have a bad substratum, we should take care. But generally speaking, long-term sports are good.
Well, I would agree 100%. And you'll recall, my friend, that you gave me the title of the talk. I didn't present you with the title of the talk. So indeed,
you're correct.
The point that I hope I left everyone with is that although we do work with athletes that develop heart disease, that on the balance, the benefits of high levels of physical activity, even into very old age, far outweigh the risks.
Something very important that is data from you, published in the New England Journal of Medicine. You were the senior researcher, author, although you were very young. Thousands of marathons and races were being performed around the world until COVID-19. Let's say they will start again one day. And according to your data, where you put the ambulances if you are short in money?
Well, that's an easy one to answer, I think, independent of COVID-19, and that is that bad things happen within sight of the start line and within sight of the finish line. And that's because when you think about the experience of not only marathoners, but triathletes, anyone that participates in mass endurance sports, they are forced to stand still and wait in a holding bin. And all of a sudden a gun is shot or a whistle is blown and they go off the line at full tilt. So there's a surge of sympathetic activity, which again is the most potent trigger for underlying heart problems, whether it's arrhythmia or coronary plaque rupture. And then they get into their race and they move along at the same pace until they round the corner and they see the finish line, at which point their moderate intensity is thrown out the back window and they run or they cycle or they swim as fast as they possibly can to get that finish line. And so if there's a threshold for ischemia or arrhythmia, that is the place where they're most likely to overstep that. And so if you have two places to put ambulances, it's where the race starts and where the race finishes. And as importantly as ambulances, having people trained in bystander CPR and defibrillators.
Okay. You mentioned triathlon, Ironman, and something like this. Can you talk a little bit about sudden death in these circumstances during the swimming part of the triathlon, Ironman?
Yeah, so there are some reasonably good data that come out of Minneapolis. A guy by the name of Kevin Harris has looked at this in detail and published on this. And his data tell an important story, and that is that in the triathlon, the swim is where the vast majority of adverse events occur. This is where the most cardiac arrests happen. And there are probably a number of different factors that are responsible for this. So the first, and probably the most important reason why people die during the swim of a triathlon, is that triathletes have a tendency to swim over one another rather than next to one another. So simple drowning can and does occur. The second, and this is just what we were talking about with marathon running, is that these athletes are standing still or oftentimes floating in cold water, and then they start swimming very quickly once that whistle is blown, with a huge surge of sympathetic nervous activity. So again, if there's a heart problem waiting to go wrong, that's a great way to make it go wrong. And then the third, and I think the most intriguing thing we're still learning about, is this issue of swimming-induced pulmonary edema, or SIPE, which is a non-cardiogenic form of pulmonary edema. It tends to be most common in women around menopause, so 40 to 50-year-old women who wear wetsuits and who swim in cold water. And the thinking is that all of these factors cause a redistribution of blood volume from the periphery centrally, which overwhelms the pulmonary capillaries and produces pulmonary edema. So if you ever work in the medical tent at a triathlon and you see people coming out of the water and transitioning onto the bike, you'll hear lots of people coughing. And some of that coughing is just them clearing the water out of their throats. But if you actually listen with a stethoscope, you'll end up hearing a fair bit of crackly pulmonary edema. And most of this resolves quickly when they get on the bike. But in some people, and we don't really understand all the risk factors yet, it can be severe enough to cause significant disease and even cardiac arrest.
Just trying to be provocative. Any chance there is a relationship with long QT syndrome number 1?
Sure. No question.
No, you think
if someone has long QT syndrome?
No. These guys who died during triathlon, any chance that they were people with long QT number 1 syndrome in the papers?
So. I mean, that's sure. I mean, channelopathies are an important cause of sudden death, with long QT being one of them. And we don't have any autopsy, certainly any molecular autopsy data from these people to substantiate genetic heart disease, but it's got to be on the list of reasons why it could happen for sure.
In this same line, aortopathy and Marfan syndrome, Loeys-Dietz syndrome, these guys with this huge aortas, do you think they should be tested for our fibrillin 1?
So in our cohort, these men that had aortas that were 40 or greater, or women that were 34 or greater, all of them underwent genetic testing, not only for fibrillin 1 defects, but for the entire panel of people of what we know causes aortopathy.
And
we saw no gene hits at all. So indeed, if you meet an athlete in the clinic with a big aorta, I think it's not unreasonable to do genetic testing and to follow them serially. But again, as our story continues to unfold, I think we're going to find that this is not a genetic issue for most people.
Okay, I agree with you completely. There is a question from Oscar Ernesto, my friend from Montevideo, Uruguay. What is your opinion about including physical capacity into risk scores?
I think it's probably the biggest omission from the traditional risk scores we have. And I think it really underscores how limited those risk scores are. So for example, if you look at the ASCVD risk calculator that many of us now use, which takes into account measurable things like cholesterol, like smoking history, like blood pressure, and you ask, why is physical activity not included? It simply wasn't included because the people that put together that score didn't have the data to include it responsibly. And that's not because they don't believe it's important. It's just because they couldn't go through the analytics process of figuring out how to weight it and include it. So I think now that we are in the era of wearable technology and data around physical activity are being collected in many large cohort studies, that we will find in maybe 5, maybe 10 years, that these scores will change dramatically with respect to how physical activity is included.
One of the faculties, Claudio Gil Soares de Araújo from Rio, he's asking, may I suggest that future studies in this matter age group should separate subjects into clearly distinct groups: long-term healthy life versus former actual high-risk factor. Otherwise, all of the findings would be hard to analyze. What do you think about this?
Oh, I couldn't agree with Claudio more. I mean, this is the point I was making about the carefree 20s and 30s, and that is that there's a big difference between an athlete that has maintained health and wellness from teens all the way through till 70s or 80s. A very different picture than people that turn to sport in the second half of life to try to get themselves healthy again. We know across countless data sets that what happens to the body in the early years, so as early as the teens and the 20s, lays the foundation for health as we age. And so I think what Claudio is getting to, again, and this is the point I made in my talk, is that when we meet these people, and indeed when we try to study these people, if we don't account for the early portions of life, we're missing an important determinant of health and wellness.
In secondary prevention, if you in a it's just a single question that I came to my mind. What do you prefer, statins or exercise?
Oh, if I had to make the choice,
Yes.
and the caveat to this is that we're not talking about people with familial dyslipidemia. We're talking about regular elevated cholesterol. I would always choose exercise over statins.
Why?
Because the data are clear. If you compare the absolute risk reduction that's conferred from exercise versus those with statins, exercise is beneficial by an order of magnitude more. Now, the best case scenario is we exercise and we're on a statin if we need it. But in the situations where you simply cannot get an exercising patient to tolerate a statin, and I will say those should be relatively few and far between if you're creative with statin dosing and agent switching and the use of coenzyme Q and days off. There's lots of tricks of the bag. But if at the end of the day you simply can't get an exerciser on a statin and they have mild to moderate cholesterol elevation, I would choose to allow them to continue to exercise rather than be on a statin.
Okay. Any other question from the audience? We are almost, it's 1 o'clock here in Porto Alegre. In Boston is noon. Aaron should have his lunch with his 3 kids right now. And I would like to thank you very much. There is the last question. Another faculty, Anderson Donelli da Silveira. As you mentioned a little about exercise after COVID-19 in your lecture, I would like to know your opinion about this elevated troponin level and myocardial edema on MRI, even in asymptomatic individual.
So, do we have another hour? This is a complicated topic. So first, and one that I will be the first to tell you we don't have all the answers to yet. The issue of troponins is complicated. I think that if you're going to check a troponin in an athlete who had COVID-19, you absolutely have to ensure that they've done no physical activity for 48 hours prior to that troponin test.
Perfect.
Even 30 minutes of treadmill work will cause a troponin bump, and you're going to end up with false positives. Cardiac MRI to look for myocarditis has been studied in the context of high pretest probability of disease. So people that present with symptoms suggestive of myocarditis. That is not how it's being used in COVID-19. It's being used as a screening tool in largely asymptomatic or mild severity COVID cases. We're going to learn the same lesson we learned with ECG screening 2 decades ago, and that is if you apply a test without good normative data, you're going to create more problems than you solve. So I think, to put it simply, in an athlete with a high pretest probability of myocarditis following COVID, which is defined by symptoms suggestive of myocardial inflammation, that MRI is a useful confirmatory tool. But to use it in the absence is going to cause more harm than good.
Okay. Aaron, thank you very, very much for your participants in this beautiful meeting. I think the 4 lectures we had were fantastic. People who were able to be with us online really appreciate. I got a lot of messages from different parts of Brazil and some parts of the world that they really enjoy the 4 lectures, and I was sure that inviting Nathan, Andre, John Myers, and Aaron, this is, it's a goal. So thanks a lot again. And before saying bye-bye to everybody, I would like to remember some things that next Friday, 6 p.m. here in Brazilian time, we will have the Brazilian Professor Night. So Cláudio Gil, Anderson Donelli, and Luiz Eduardo Ricci will be the faculty who will be talking about different and very interesting subjects in the area of sports rehabilitation in cardiology science. Then on October 31st, we will have another 4 invited guests. The faculty will be Jonathan Presner, Mats Borgesson, Sanjay Sharma, and the other one, sorry about my My God. John Dresner, Sanjay Sharma. I'm Lorenzo Monserrat, my my mentor in Spain in 2015. Sorry, Lorenzo, about that. So thanks a lot. Be with us next week. Nathan, John Myers, Aaron, you stay with us right now. Thank you very much. Andrew returned to his call. Professor Sandra, congratulations for all you gave us. Fantastic, simply fantastic.
You don't have to thank me. Just thank you, the speakers. They were fantastic.
They were fantastic. Also, in their explanation, we were able to interact and see how much they can teach us. Thank you very much. Have a great weekend. Be aware about COVID. It is around. And Aaron, John, and Nathan, bye bye from my heart. Thank you.
Thank you.